Okay, 1 p.m. sharp. Well, thank you everyone for joining today. Hopefully you guys can hear me online. We have a small but mighty group here in person. So thank you to those who were able to make it in person, but also thank you to those who are virtual. So always glad to be able to have folks join this quarterly meeting. It's one of the areas that I look the most forward to. And one of the areas that I feel like Michigan as a whole shines. So not everybody in every state has a RHC network the way we have. So I feel very blessed to lead our network. And with that, I always like to start this meeting with a recognition of our Michigan RHC Network Board. Of course, we have Keisha Sexton. She is from the Northern Pines Health Center. She is our president. We have Wendy Langworthy. She's the director of operations at University of Michigan Sparrow. And then we have a number of member representation too. We have Laura Green. She's the director of population health at Aspire, and Ruanne Vanderveen. She is not the quality assurance and improvement coordinator, but she's the practice manager now. I forgot to update hers. And she has been for a little bit. So she's with Sheridan Community Hospital. Tammy Wall, again, manager of physician practices at Sugar Health System, and Terry Breck. She is the Rural Health Accreditation and Education Specialist, also from the University of Michigan Sparrow. And then Laurel Sawyer, she's the Director of Quality Population Health from Trinity. So this group, we meet monthly. They help guide the content that we have for our quarterly meetings. They help really ground me in what's most important to the RHCs right now. They often get preview and sneak peeks of some of the things that we're working on. But I'm able to pick their brain throughout the year, each month, when I have something that I really need feedback on. So I appreciate this group immensely. Of course, this year we changed things up a little bit for those of you who are new and just joining us and haven't joined one of the network meetings before. We always give some updates. We try to include legislative updates, which there's a lot of things happening in Washington right now. Please be on the lookout for notices from our office around the Rural Health Transformation Program. Of course, this is the part of the one big beautiful bill that came out, and that will be disseminated amongst rural entities. So each state has to put in an application for part of the funds. And part of it's just allocated. So there's lots more to come on this. It's very much in the infant stages. We had a call this morning with the state of Michigan. MCRH is diligent about being at the table and hearing the voices of the RHCs and the critical access hospitals and our OTPs. So our outpatient treatment providers. Those are the entities that are eligible entities under the Rural Health Transformation Program that's going to be coming out. So we want to make sure that we're capturing your voice and bringing that to the state of Michigan. So when they put their application together, that your voices are reflected. I hope to get a meeting notice out either late today or tomorrow with regards to an RHC and OTP provider specific meeting where we're talking to the clinics. We're talking to those of you who are boots on the ground doing the work. So please be on the lookout for that. We will put it out probably via our constant contact feed as well as our listserv. We know there's constant transition and turnover, but please pay attention to those emails over the next few days and try to make it to that meeting. We're looking at September 3rd at noon. Additionally, quality improvement initiatives. I'm so excited to be able to continue to do this work. We're doing some great work with Anjanette out of MDHHS, who was here today to give a presentation, but we're also partnering again with the National Kidney Foundation of Michigan around some CKD work. Every time we get an opportunity to involve the clinics in an RHC specific fashion that we can do quality work, we're right on it, and we appreciate the participation from the clinics. Leadership development is another key focus area that we like to try to bring employee engagement and empowerment, and then some workforce strategies. So we've hit a number of these throughout the year. This is our third meeting of the year. We have one more that'll be in November. So sadly, we're halfway through, a little more than halfway through summer, being that it's our August meeting. So we'll have one more meeting that is November 13th. That will be a virtual meeting. So we will be sending out that information over the next month or two. Leah's been great at keeping everybody connected with the meeting information and doing a lot of our logistic work. As I mentioned, for our year goal, we have been focusing in on diabetes, quality of care. And that's something that we've brought topical information to each month. This month, we have CGMs and diabetic retinopathy. Again, some of those things that we know we have to have our patients do in terms of screenings, but also some of the tools that make their effort around controlling their diabetes more fruitful. So we're excited to hear some of those things. We have our practice manager series. We started in May, so we're several months in. We are going to be closing out registration. So anybody who has not signed up and wants to sign up, you can still sign up for that. We've had a number of series already. Those are all located in the Thinkific platform. It's a learning management system that we will give you access to. You're able to go in and listen to the prior sessions, but also go in and look at any of the current content as well. So if you are still interested in registering, once you get the slide deck, this is a live link to register now. Feel free to be able to put that on your to-do list. And that's all I have for myself. I'm going to bring up our next speaker, which I'm super excited. The Zoom screen sharing has stopped. But I'm super excited to announce our next speaker. It's been some time since we had some oral health information brought to the RHCs. Emily from the state of Michigan has been working alongside Laura in our office, who does a lot of work in population health and social drivers of health, and just thought it would be a great opportunity to kind of bring some focus back to some oral health and dental health for the RHCs. We know a lot of those rural communities really are absent of dentists and resources that are right in their community. So I'm going to turn over to Emily as soon as Aaliyah gets the PowerPoint. Can everybody hear and see okay online?
While she's getting that pulled up, I'll just introduce myself. Hi, everyone. I'm Emily Norris, and as Jill said, I am with the Michigan Department of Health and Human Services Oral Health Program. And so my position is a relatively new one. I've worked within the oral health program for a decade on perinatal and maternal and child health issues, but we were able to use some funding to create something to work with rural communities, because we know this is a huge challenge in rural communities to access care. So I'm excited to be able to start to work on that. And if I look tired, it's because I am, because I have been road tripping the UP. I'm on my way back down. My manager, Chris Farrell, the oral health program director, is here with me. And we have been since Monday from Lansing to Escanaba to Harris to Marquette and to the Sioux, and now on the way back down again. So we have been on the road working on some veteran oral health stuff up in the UP. So that's been really exciting. But I'm happy to be here with you to give kind of a high level overview of just the state of oral health access in our rural communities right now, which we know, frankly, is not that great. So this is going to be a pretty high level presentation. If you want more in depth, I'm happy to do that for you. You can reach out to me. I'm happy to talk about specifically what's happening in your region of Michigan, as well as resources that might be helpful to you. But yeah, we're going to go ahead and get started. So I'm going to start with a good old HPSA map. We all love a good HPSA map. This is for dental shortages from March of this year. And so as you can see, our rural communities are all pretty much generally some pretty high HPSA scores in dental. These have been roughly the same for a while, not a lot of movement in that area. But as you can see, the UP and then kind of north central Michigan is especially struggling. Yeah. So we've been doing, as part of this initiative, some asset mapping, and we've started with the Upper Peninsula, just because we know the need is, well, frankly, it's bad everywhere. We know North Central Michigan, the Thumb, and the UP are some of our hardest hit regions. But we started with the Upper Peninsula, and so we've basically been going through and just identifying assets where gaps are. And so we're going to be having a report coming out on that. So this is a sneak peek, but this is a snapshot in time of Healthy Michigan Plan providers right now that are in the UP, and the number of them in a county. So as you can see, we have 3 counties without any Healthy Michigan Plan providers for dental. We have a bunch of counties with just a couple, and then Marquette's coming in with the most access. Again, not probably surprising to anyone here. And then we can also look at Healthy Kids Dental, both plans, because we have the Healthy Kids Dental Plan with Delta Dental, and then the Blue Cross Blue Shield plan. And as you can see, these are the number of providers and counties. Yeah, so we can see we have counties without any dentists who will take kids Medicaid for dental. And we have many counties, there's only really 1 or 2 dentists at all. We need about 300 dentists to solve our workforce shortage issues. I don't have 300 dentists. I wish I did. I would drop one off in every county. And be like, here's a dentist for you. Here's a dentist for you. And so this has been an ongoing issue. I'm sure anyone who's been in the rural health space knows this has been a struggle for a long time, but it is getting worse. We know it is. And right now we're facing a lot of dentists, especially in our rural counties, that want to retire. They've spent their career working with rural communities, and they are having a hard time recruiting younger dentists to come and replace them. So this probably is going to get worse before it gets better. It's not just dentists though, it's the demand for hygienists and dental assistants. COVID really decimated the hygiene workforce here in Michigan. A lot of hygienists retired during COVID. Dental was shut down and they said, you know what, I'm done. I'm just gonna call it. I'm in an age where I can retire. I've had enough. And so we lost a lot of hygienists. And so we're trying to recover from that. But yeah, there is a huge, huge need for hygienists. We have seen salaries, you know, people saying, I'll pay you $70 an hour, same day pay. I mean, that kind of a thing. So it is really high demand right now. And dental assistants as well. Really struggling. That's a high turnover field. We know that can be a hard position. But we need hygienists and dental assistants to have a dental office run. So we're really kind of struggling on all fronts. We're seeing schedules book out to about 1.5 years in advance. I'm sure many of you are seeing this as well in your communities. I know in Northeastern Michigan, where I am from originally, I've talked to providers and yeah, 1.5 years out. If you have an emergency, they might be able to work you in quicker, maybe, so you don't end up in the ER, maybe. But if you just call and say, I need a new dentist, I'm looking for, you know, an annual cleaning, they're gonna book out about 1 year, not more. If they're not taking patients. There's really not quick solutions for this. I wish there was. Okay, we just need to do X, Y, and Z, and this will solve this problem. But it's really not a quick fix. There's a lot of fixes that could happen, and we're working on them. But these are all long-term efforts. To, you know, recruit a dentist to come into a community, that's a long-term thing. That takes time. To have a pipeline to bring in dentists to a rural community, that takes time. So it is definitely challenging, and just trying to think outside the box for this. We really are working with different communities. What could we do that hasn't been done? You know, let's try it, because frankly, it's a huge struggle. Frankly, we need rural residents to go into the dental professions. And that's one of the things we really want to focus on, because we know kids from rural communities are more likely to go back to rural communities or stay in rural communities and practice there. So I know right now Northern is looking into the possibility of putting in a hygiene program, which would be huge for UP. Absolutely huge. I cannot quantify how good that would be. Right now, if you happen to live in Houghton, let's say, and you want to go into hygiene, your nearest program is in Big Rapids or over by Saginaw. That's like, what, 8 hours? That's equivalent of going out of state. I mean, that's just not feasible for a lot of people. Or if they do it, they might not end up coming back, right? So it is, to have a program on the Upper Peninsula would be phenomenal, especially if I know that program would really work on recruiting kids from the UP, which would be the goal. We'd really be able to have that pipeline. I also want to mention some of the dental assistant programs that are happening right now. We're having a lot of the FQHCs, also Upper Great Lakes in the UP, and as well as down here in the Lower Peninsula, have a grow your own dental assistant program with the Michigan Primary Care Association has been working with them on that. And so that's been really successful. Pay you while you train into a position, pay for any education you need while you're working. It's been really successful. So I always tell people, if you know someone who's interested in, you know, dipping your toe in the dental career, it's a great place to start with essentially no money put out by you. Everything will be paid for with immediate work. Good deal. So emerging challenges. What's some of the stuff that's happening right now that you should be aware of? And you probably are aware of. Fluoridation opposition. If you haven't been living under a rock, you've probably heard some things about fluoridation lately. So yeah, that's happening right now. And I'm going to touch on that briefly. I'll be honest, that is something that could take 3 hours to discuss, and we don't have that today. So I'm going to give you some resources that I found really helpful, and then I'm happy to circle back around and have a more focused conversation on that. Medicaid uncertainty. In Michigan, we have a pretty robust adult dental benefit. We've put a lot of time and effort in getting that dental benefit. Adult dental is not mandated. So, you know, as Medicaid cuts happen, kids are fine. Kids are mandated to have coverage, and they do a Healthy Kids Dental. And we do for adults right now, but what that will look like long-term is frankly uncertain. So we will see. We're having a lot of providers drop Healthy Kids Dental, or they're unable to take on new patients. It's not because they don't want to. They see the need in their communities. They want to be able to do these things. They just don't have capacity. They physically cannot take any more patients into their practice. And so, I mean, we're seeing that, especially in the Upper Peninsula, there just isn't any more capacity. And we're also seeing an increasing number of providers leaving all insurance networks. And yeah, there's definitely a movement within the dental world of kind of a do-it-yourself. You pay up front, you submit to your insurance company and hope that they reimburse you enough for the cost of that visit. I get it, dental insurance is not great to work with, it can be complicated. I understand that. It also prevents an access to care challenge for people who do not pay $500 up front, right? And hope that insurance reimburses them. So definitely we're seeing that happen a lot, also in the Upper Peninsula. So sometimes we're having the only dentist in the county is now going that route. Can be a problem. So what's on the horizon? As I mentioned earlier, we have a feasibility study happening right now with Northern Michigan University. It would be incredibly helpful. That would be amazing. Just a wonderful thing for the Upper Peninsula and Northern Michigan. There's also another college, North Central Michigan College in Petoskey, is looking at starting an associate's program in hygiene. That's in the early stages. I don't know how that will pan out, but they're trying. I'm sure many of you have heard of dental therapy. Have people heard of dental therapy before? Yes, no? Okay, so dental therapy is kind of a new profession. It is legal and allowable in Michigan. Can think of it as an PA or an NP, but for dental. That is the easiest way to say that. And so this is becoming quite popular in other areas of the United States. Again, it's legal in Michigan. We are about to have our first practicing dental therapist will be up in the Sioux. And so this will be exciting once we can get this program up and running. And so a dental therapist can do, they're looking at fillings and basic extractions, kind of that middle range of dental things, leaving more difficult procedures to be done by a dentist who can practice the top of their licensure. And so dental therapy has been around a long time within the tribal communities. They're one of the people who started it first because they also had no dentist. They said, we're going to do this instead. And it's really spread. And it's pretty great. So I'm excited for this to happen and for us to start seeing more dental therapists in Michigan. It's going to take some time. Again, for this to have impact, it's going to be years slowly for this to come. But eventually, I'm hopeful that we think of PAs and NPs. We couldn't imagine practicing medicine without those professions now. I'm hopeful that dental therapists potentially can come in and kind of play that same role, right? And lastly, have you heard of the kindergarten oral health assessments? Yeah, so right now in Michigan, along with hearing and vision, we have added dental into assessments. And we've done that because the rate of dental decay in kiddos is bad. And I'm sure if any of you working in a clinical setting have seen that. I can tell you right now, 1 in 4 kids being screened with COHA, what we call it, has urgent dental needs. So these kids have infections, their mouths are blown up. 1 in 4, 25%, and higher in some counties, specifically in rural communities. So yeah, I'm excited about this program. It's just really showing the depth of need that we have here in Michigan.
Quick question on it. In terms of the 1 in 4, what are they seeing? Is it cavities? Is it other?
It's decay and infections.
Okay.
Yeah, I mean, kids' teeth are completely, what we say, black, gone, little stubs, swollen infections.
What's causing that though? I mean, like.
Lack of dental care, lack of taking care of your teeth, sometimes unfluoridated water. If you don't have that boost, if you're on private well water and you're not getting that daily fluoride, that can contribute to that. You're not getting that protection. Just if you haven't been to the dentist by the time you're 5 and you're not taking care of your teeth, you're going to see this. And it's incredibly common. We promote H1 dental visits because we like to get a start on this now because we see kids at our programs across the state who are 2 when their mouths are bombed out. And so by the time they're 5, it's pretty bad. Yeah.
Which then, of course, affects the new adult teeth.
Correct.
Yeah.
Yes, absolutely. Yeah. So a couple tips, just things. When people say, how do I know where I can find a dentist? They can if you're working with someone who's like, I don't even know what I can, who could be my dentist, what will my insurance cover? They can contact their dental health plan or their Medicaid health plan is what we tell people to try to, like, where do I even know what I can do? So that's step 1. I do want to also mention that beginning in 2024, Medicaid health plans are required to provide transportation to dental services. So if you have patients who say, I don't know how to get to the dentist and you have Medicaid, Medicaid will cover that. You have to set it up. But that is mandated to be covered. Going back to adult dental, that Medicaid for 21 and over, back in 2023, we raised the reimbursement rate to 100% of the average commercial rate. So that was a massive increase in reimbursement for dentists. And we even put it in so that we'll follow that rate as it goes up, right? It's been put into law that way. So it won't just be stagnant at that amount. As things change, it will follow it up. And also that includes crowns, root canals, and we call periodontal therapy, which a lot of people need. If you haven't been to the dentist in a long time, they're going to want that periodontal therapy to be able to do any other dental procedure. So this is all now covered by Medicaid.
At 100% of what commercial rates are.
Yes. Yes. We still have a significant problem with dentists accepting Medicaid though.
Do they recognize that they're going to get paid
Yes.
like a commercial rate?
Sometimes, yeah, most of them know. They just don't want to take Medicaid. And there's challenges associated with that. We don't make it easy to sign up. I won't lie. The process that we do for dental is complicated, and I wish I could change that and wave a magic wand and make this simple. Can we just check some boxes and go and get everyone going? It's the paperwork burden is obnoxious. You know, I think people are worried it'll go away, right? Okay, I'm going to sign up to do this. What happens if this ends? Knowing it's not mandated. You know, there's a lot of stigma around accepting Medicaid and dental as well. You know, that dental doesn't have that public health background that really the medical side has, and so it can be really hard for dentists to want to go that route. But yeah, the reimbursement is good. It's not great. It's not the best, but you're not going to lose money, right? Like you can make this work. And so we are seeing an increase in some areas that we haven't before. It's still not enough. It's better than it was.
Did anybody market that?
Yeah,
That's what I was wondering.
yeah. So the Michigan Dental Association working hard to market that. We have as well. We're pushing it. You know, all the beneficiaries were notified. They, in theory, well, through a form letter from MDHHS. I know. You know, so we marketed as best as we could. Yeah, we're trying. So RHC's in dental. So you guys can't bill Medicaid for dental services. Do we all know this? I didn't actually even know this when I started. I was like, what do you mean real health?
I only know because we've had talks about it.
I know. I was like, what do you mean you can't do dental? I'm like, let's do a project. We're going to integrate a hygienist and we're gonna do all these things. And then they're like, no, we can't do that. And I said, what? Wait, what? What do you mean? So yeah, currently, via Medicaid in Michigan here, you guys cannot bill Medicaid for dental services. Now, other states have changed this, and I've talked to some of them, and I've also talked to our Medicaid people here at the state, and they're not 100% opposed, but there's a lot of challenges associated with this. Number one right now, the Medicaid climate. I'm hesitant to do something and then the benefit to go away, right? We put all this work in because you're going to rely on that benefit to make this sustainable, right? So there's that. Could you even find a hygienist? Because it would probably be a hygiene model is the easiest one to do. You'd have a hygienist come in to do cleanings, assessments, referrals. Could we even find a hygienist to work in the setting when we can't even get one in a regular clinic? A huge challenge, right? That being said, if we can eventually, once things stabilize, we'd love to talk about this. If there was an area or clinic who wanted to talk about this, we're happy to do so. And Medicaid wasn't completely dismissive. It's just not the time right now. I think there would be interest in the future in looking at this. Pennsylvania is the one state who has changed this. They started a hygiene only program and it went so well, now they have full dental clinics. It's been incredibly successful. So something to think about. I do want to mention though that you guys can do fluoride varnish right now as part of a medical encounter. And if anyone is if you're not doing fluoride varnish, you can. And if you currently are, we're like, oh, maybe we could do that. We can give you varnish for free. Now I will say you do not get paid for that varnish. It's a separate encounter. It's wrapped up in the medical one. I wish I could give you guys more money. We can't. It's wrapped up in that typical medical encounter. However, we can give you free varnish. It's a minimal training. You're part of the Varnish Michigan program, and it's biannual reporting that's super, super minimal. It's just a couple pounds of things. It's not a huge burden. We wouldn't do that to you guys. So if that's something you're interested in, you can reach out to me or my colleague Heather, who runs this program. Yeah, and it's cool too because you can delegate that varnish to an MA or a nurse. So that provider can say, yeah, we're going to put fluoride varnish on this kiddo, and the MA can come in and just paint it on. So it's an easy intervention that's not a huge time commitment from a clinical perspective.
You guys offer free toothbrushes and toothpaste and things like that to hand out to parents as
We,
well?
we generally point people to like Delta Dental because
Okay.
they will give you supplies. There's an
Okay.
online portal to request for things. And we typically just say to go through them because it's easier.
Yeah,
But yeah, I can help point you to that if you want, and that's something you can do. You can request things, I think, almost biannually or quarterly.
I'd have to look, I think
Yeah.
it's biannually.
Yes,
I just figure if you're doing the fluoride, it's a great.
yeah,
opportunity.
absolutely. And they would send you toothbrushes in bulk and then you can
Yeah.
hand it out with that and do like a whole little dental kit.
Well, that would be fun.
Yeah. So fluoridation. Now, as I said, I'm not going to get into the depths of this because it's complicated and I want to do it justice, and this is not my area of expertise. My colleague Sandy, her entire position is fluoridation. So she is the one who is just the knower of all fluoridation. However, I do want to touch on it a little bit. I don't know if anyone's been getting fluoridation questions in clinics, if you've been hearing buzz about it. So if you have, whether you have or haven't, I want a couple of things. I like to tell people that because a lot of times people are concerned about adding fluoride as like a chemical added in the water. Michigan's naturally fluoridated across the board in a lot of areas. You know, we fluoridate at 0.6 or higher. However, a lot of Michigan's already at 0.3 to 0.5 just in the water. To find out if you're on well water, it can vary wildly. You can get your well tested. You can send a kid into the health department and tell you like your fluoridation, how much is in it. I grew up in rural northern Michigan on a well with no fluoride, so I took a fluoride pill every morning. My dad was a dentist, so that probably contributed to that, but yes, I took a fluoride pill. And in my elementary school, they did the fluoride swish programs. I don't know if anyone ever had those. We swish fluoride in our mouth, we spit it in the cup with we put in paper towel and we throw it away. And then we eat popcorn after, which I don't think you're supposed to do and probably negated the impacts that it had. But so yeah, I just want to say fluoride is actually pretty prevalent naturally here in Michigan, but we do supplement to the ideal range of 0.7 in community water systems when needed. I want to tell people there's something called My Water's Fluoride. You can look up your community right now and the systems within it and see what's fluoridated and what isn't. Essentially, it will tell you, you can search, you can go to the state, you can select the county, and you can select the water system, or you can look at the average fluoride levels by month, by state, and it'll go through every single area that we add fluoride to, and it will tell you what levels are, or all the water systems, if they're fluoridated or not, so you can see what's in your area, if you have any public fluoridation that's happening. Because sometimes people want to know, they don't even know, right? Like what water system I am I getting fluoride, am I not getting fluoride? I want to point you to 3 resources, and these are the best ones that are out there that we just highly recommend. There's no point in me creating a resource when these are just the gold standard. So I want to point you to the American Academy of Pediatrics, who kind of has 2 things, a general fluoridation page, and then I like my teeth. And this is the gold standard, especially for consumer-facing information. Infographics, posters, easy to read facts, all at a decent reading level, all very well done. It's phenomenal. And they really lay out, like, this is what the argument is, this is the concern, this is what it is. They do a nice job of really showing both sides, why things are okay, where anything is at. They do it great. And then this one down here is through the ADA, and this is more clinically focused. And they pretty much have every single question that's ever been asked about fluoridation. I mean, like every single question. It's hundreds of questions has been answered like clinically. So it's a great resource for providers. And so these link to all of that. Highly recommend it. And you'll be ready to answer any questions if you go through that. And if you want to dig deeper into fluoridation, my colleague is Sandy Sutton, and she does a wonderful presentation. She'd be happy to talk to you, talk to your clinical staff, talk to your agency, talk a little bit about what's going on in your own community, get into some of that, and she does it really well. So she would be happy to hear your questions or be reached out to give you some more of that information. So as I wrap up here, some practical takeaways. Know the dental situation in your community because it is different for every single community. I think it's really, really important to know who takes what insurance, who are your Medicaid providers, who are your sliding fee providers, who are your providers who don't take insurance at all, right? And so, because if you're going to make a referral, you don't want to refer the person to the wrong dentist and then nothing is going to happen from that, right? Know what the wait list looks like. And so that could change. It's just really helpful to really get to know your dental community. I also think it's helpful to inform patients about dental shortages because they don't know a lot of times, right? They have to really grasp it is important for you not to miss your dental appointment, not just because we want you to have healthy teeth, but if you miss it, it might take you another year to get back in, Like, this is one of those appointments you cannot miss because it's going to take you so long to get in. If you miss it, you're gonna be in trouble. We're gonna go around again. So we really want to communicate that to just to families so they understand kind of the situation and what they need to do just to prioritize that. I especially say in the Upper Peninsula, I mean, obviously we want everyone to get 2 cleanings a year and do all of that, but you know, we only have a couple oral surgeons in the entire Upper Peninsula. We only have a couple endodontists in the entire Upper Peninsula. If you need care that goes beyond what a general dentist can provide, it's going to be even harder. And so we just want to communicate that it's more important than ever to make sure your teeth don't get to that point, because it's going to be even harder to find that care. You might have to go across the bridge. You might have to go to Wisconsin. You know, you might have to wait. We don't want that. So people just need to be informed about the situation. And lastly, the fluoridation debate isn't going to go away anytime soon. So I think it's really helpful just to prepare yourselves to be a resource for patients. The reality is a lot of patients in rural communities do not have a dental home. And so they might not really be getting any information about oral health and fluoridation, or what they might be getting might be coming from the news or the internet or Facebook. And so I think it's really helpful just to have a baseline of knowledge from a medical side, so you're there to answer any questions that might come up, because frankly, you might see that person more than a dentist does. So with that, I don't know the timing. We have time for
Oh, we
questions.
got lots of time for
Okay.
questions.
I'm happy to answer questions.
And for those of you who are online, if you would like to ask Emily a question, you're welcome to come off mute or just put it in the chat and we can relay that question. So Emily, one question that I have, and as you're talking, and especially with Laura's question around supplies that you can give to patients, when you think about primary care and what other practices are doing, whether it's fee for service, FQHCs or RHCs, have you seen any programs or robust assistance that your primary care providers do that could be replicated, that we could put together and that we could share with RHC? So they're obviously they're not going to have dentistry within their clinics right now, but what is it that they can do? Resource bags, information, what does that look like?
Absolutely. So as I mentioned, the gold standard we really have in some of our FQHCs, we have hygienists embedded directly within medical clinics. Unfortunately, not an option right now. Hold that thought. I'd love to discuss that further. So that is the gold standard, and it's amazing, and it works, and the outcomes are wonderful. However, we do have other programs happening within, especially pediatric practices, where we're doing pediatric training for residents. If you have a bunch of peds residents or family practice residents, because they don't get any oral health training, like only a few hours during medical school, we are happy to come in and provide an oral health 101 and just how you can do this. What do you need to look for within a clinical setting? When you have a kiddo in front of you in for a well check, like what do you look for in a mouth? What do you need to do? When do you need to refer to CPS if there's not being, you know, if it's an abuse issue, do we get to that point? Because that does happen. All that kind of stuff we can discuss, and we can come in and do those trainings. And those have been pretty well received, I think, in clinics that we have done those in. People like that. And with that can come fluoride varnish, yet whether or not you want to do that, we can offer that as part of that. I think.
Do you see clinics giving out like little resource bags or?
Absolutely do that. And honestly, not trying to plug Delta Dental necessarily, but honestly, they are the ones who are awesome at funding these kind of things. So they have constant mini, not constant, a couple times a year, they have mini grant applications you can apply for. It's a very simple, trust me, in terms of grant writing, it's like a page of just like what you want to do and why you need it. You can help apply, you can do it and say, I want to do resource bags. I need 3,000. That's going to go across a network of whatever. And then there's a good chance they might be able to fund that. And you'll be able to purchase those supplies and hand them out at visits or in the community. Absolutely. So those kind of things 100% exist. You could reach out to me and I can help you connect you with those resources if that's something your clinic is interested in doing. Or anything else you want to do that's anything oral health related. We touch a lot of the state and a lot of different, different programs. We have sealants within schools. We oversee mobile dentistry and what we call PA 161, which is like hygiene programs within the state. We work with individuals living with HIV. We have a separate dental insurance program that is that helps cover those living with HIV for dental needs. We have, as I said, fluoridation. We have perinatal oral health programs. We're working with community health workers and helping pregnant people connect to dental care. So if there is something you want to do oral health wise, please reach out to me and we can probably discuss it and we can talk about it and probably connect you with what you need.
That's awesome.
I just know at my pizza office, they used to do the fluoride and then it gives a little bag. and-
Yep, yep.
Like, it's been a while. The
Yeah.
kids aren't that small.
If they want to do it, we can give it to you.
But we do have some pediatricians, maybe they'd be interested in some training about.
Yeah.
You said they only do a little bit while they're in their coursework, so.
Yeah, they really don't get into teeth at all.
Mhm.
Anybody here in person or online, provide additional resource to their patient population, whether it's like a little resource bag, whether it's referring your patients over for specific dental care or specific programs. If you do, you can drop it in the chat. One of the things I know out of our office, Laura Stoddard has been working heavily. She's a former dental hygienist, so it comes close to her heart. That would be great to be able to provide additional resources for RHCs, especially if you're in a really remote area and you don't have dental practices near you, or you have a dental practice, but they don't take Medicaid. You know, what is it that we can do from the RHC perspective in the RHC world that we can do to support the community and support the patients who we serve? It may not be dental care right out of the clinic, but if there's additional resources that we could supply.
Yeah.
I think it would be great to be able to have some kind of program or some kind of system that we could replicate and share with RHCs across the state.
We have in our communities the mobile dental that goes to the school system.
Yes, yes,
I have to make sure to say, no, we go to the dentist, but they still take a look at the house.
yes. And so we at the state oversee those mobile programs.
It's great.
Yeah, there's a variety that go across the state. Some are with a program called Seal Michigan that we oversee, and there's the ones who go into do school-based sealants.
Mhm.
But yeah, they're all over. It's helpful. It really is, especially in rural communities. It absolutely is, especially when they can do some comprehensive services.
It's something to bridge the gap.
100%. I do want to mention also that in some of our rural communities, through the Upper Peninsula, I'm thinking of Marquette Health Department, LMAS, Grand Traverse, District 10, District 2 and 4, in mid-Michigan, all have a hygienist embedded within their health department. Which is really cool. So if you're working with the health department at all, those hygienists are working with primarily with the COHAP program, the kindergarten oral health assessment, but they do other things too. And they're out in the community. They know the pulse of the community. They know who's taking what insurance. They know how long the wait is. They are in and out of the schools. They are putting the boots on the ground. And so, they're a wonderful resource in terms of even if you want someone local, right? If you say, well, I don't want the random girl from the state of Michigan, I want so-and-so from the local, it's okay, I'm not offended. If you want someone from the community and say, you know, I live in West Branch and I really love someone from this area, I can help set that up for you and connect that. And so really, it's been a wonderful program. I love to have a hygienist in every single health department in Michigan. I think it's wonderful. We'll get there eventually.
Awesome. Any other questions online or here?
And Chris Farrell, the oral health program director, is
Oh,
with me, is
well,
raising her hand.
I just have a comment
Yeah.
and for something for you to think about for the future, because I saw your agenda is about on diabetes.
Yes.
Yes.
The exam rates and different things. One of our new projects with the CDC is with oral health and diabetes. And I haven't, this is fresh off the email, is that we now have through CHEER, we work through U of M, get some Medicaid data. We just this week got some data between oral health and diabetes. So maybe we can talk later about providing some information about the connection between oral health and diabetes too. And I know because many of you are interested in the diabetes
Absolutely.
topic.
Yeah. Any additional resources we can layer in and education we can layer into our RHC leaders, it's fantastic.
Yeah, and please, as I said before, I keep saying this, please reach out. I have a lot of very county specific information that we just don't have time to look through today. But you're saying, I live in Alcona County and I would love to know how many people on Medicaid are going to the dentist. I can tell you that. And I can tell you your ER utilization, like what rate of people are going to the ER for dental by Allen County. We just got that data. So if that's something that's interested, please reach out to me and I can share some of that with you and kind of give you a profile for your area. I sometimes find that helpful to kind of show the, the depths of that picture and what's actually happening.
Fantastic. Well, thank you, Emily.
Thank you so much
We
for having
will,
me.
we will share the slide deck.
Yeah.
So Emily's contact information is on this last slide. Post the meeting today, we will share that slide deck. So if you would like to reach out to Emily, please do.
Thank you so much for having me. I appreciate
Thank
it.
you again.
Thank you.
go home and get some rest now that you are finishing up your road trip.
I will.
Absolutely.
Thank you.
Well, I'm excited to introduce our next speaker. We have Monica Powell. She is the parent liaison from Delta Schoolcraft Great Start Family Coalition. So she drove down from the UP today. I had the pleasure, well, a couple of different encounters. I had the pleasure of speaking with Monica with Laura Stoddard from our office. She was on call and just really shared some great information. And I said, oh, the RHCs would love to hear this. You know, I know many of you are always looking for resources and tools and additional things that you can support your patient population with. She focuses in on exploring how the coalition strengthens early childhood development and connects families to care with ideas for RHC collaboration on the whole family support. So although she's from a specific county, she'll go through all of the information of what's available in other counties. And on top of that, I happen to be doing a site visit down to Bronson, one of the clinics down there, and they had the Great Start Coalition, and they had some really cool things. So come on up, Monica. Just use the arrow to advance your slide.
Okay, perfect. Well, thank you for having me. That was a great introduction. That's perfect. I mean, that's basically what I'm gonna say, so. So yeah, as she was saying, I kind of got on track with Laura at one of the parent meetings that they had in Schoolcraft, and they were looking for parent voices slash community leader voices as far as what is the community missing, which is actually really relevant with your last speaker with the dental, because wow, that was one of the things that a lot of our parents were talking about was the lack of our dental facilities in there, especially because our main one does not accept insurance. So that really hit home. I was like, that they need to come and talk to Schoolcraft County because it's needed, and it's one of those things that we are lacking. So it's just a lot of opportunities, especially when you do live in a rural area, that you don't realize that you kind of miss, especially if you're living in, you know, one of those bigger sites. So Great Start Collaboratives and family coalitions are everywhere in the state of Michigan. One of the first questions that they asked me actually was, are there other Monicas around? And I said, well, not Monicas, but yes, like they do exist. So depending on the county that you live in, there might be one of me, there might be two of me. The bigger counties sometimes have two of us. And so that way they can expand and kind of cover the county a little bit better. As you can see, we do a lot of different things. So the pictures there as far as story times, which we're going to get into, blankets, which we do with VRs, and then we do play and learn throughout the year. So it's a lot of really great things, and hopefully by the end of this, you're going to take back something to your organizations that you're like, that made an impact, or if you have any questions, you definitely can talk to me. You can reach out. I'm going to have a lot of different information as far as not just what we do, but what the state does as well. So as she said, my name is Monica Powell. I actually went to Central Michigan, so I feel right at home. I'm back to Mount Pleasant, so that's very nice. And I am the Schoolcraft County Family Liaison for Delta Schoolcraft. I've been there for about a year now. I got started because I actually have two kiddos of my own, and I was kind of looking for that connection. And a lot of parents don't really know where to look for resources or that connection with parents when you're kind of first starting or when you're a new parent in a community that's very, you know, kind of know each other. So it was a really great little spot for me. So, and also just a quick heads up, I'm going to be leaving after the presentation just because of my trek. So if you do have any questions at any time during this, please just feel free to shout. I do have a little question thing at the end, but feel free to say any questions that you have. So, so one of the biggest questions that we get is, what is the Great Start Collaborative? And it's a little bit confusing because there's a lot of starts, there's a lot of great starts, there's a lot of head starts, and they kind of all intermingle. But we are not them. So I am not Head Start. I am not Great Start to Quality. I'm not Great Start Readiness Program. I'm none of those. I'm Great Start Collaborative, which again gets confusing because they all are like, this is the same program, right? It's not quite. So it's Michigan's early childhood system. So we're birth through 8. And the main thing that we're focused on is early literacy. So we want to make sure that kids are ready for school. We want to make sure that babies are born healthy. And everything like that. So as you can see, we engage early childhood partners such as hospitals, such as, you know, LMAS, we work a lot with them as far as getting like little sleep sacks, or we just did diapers with them, and we just did a nursing cape. So we have a lot of different varieties that we can do, a lot of different things that we can do depending on what the initiative is or what our parents are seeing. A lot of opportunities for collaborations are created upon the gaps that we're seeing in the communities, like diapers, play groups, a lot of things we can't really touch, like the dentist thing. I can't really help with the lack of dentistry, unfortunately. I can't really make one up here, but we try to work with our partners and how we can make things better for parents to understand or how to get in contact with those resources. And to make things even more confusing, is that part of our thing is also the Great Start Family Coalition. So it's the same thing. It's still part of my job. So it's a sister body to our local Great Start Collaborative. So what that is that we engage parent leaders. So whether you're a grandma, you're a grandpa, you can be a stepmom, it can be anyone that as long as you're involved with the child, you're welcome to come. And the point of that is to foster then strengthen the early childhood community by connecting the families and the work with the collaborative. So a lot of the families that come to our stuff are people that are searching for connections. They're searching for that answer, you know, they're feeling a little bit lonely at home, you know, things like that. And honestly, when I first was asked to present, I was a little bit like, whoa, hesitant because I was like, how do I like fit in here? Because like, I wasn't sure if I did, but when I thought about it a little bit more, I was like, you know, we are really related with the healthcare field because health isn't just preventing illness, it's also preventing, promoting social health, which is very important, especially when it comes to small kids, especially when it comes to the elderly. And that's one of the things that has promoted our next thing, which is our story time, is that the senior population really needs those emotional connections. And there's a lot of proven studies, whether it's seniors to toddlers or that show that that connection is needed and that it helps, you know, with dementia, it helps with Alzheimer's. It just helps them get that connection because they feel lonely too. They need something to do. So a couple of things I'm going to be going over next are just different initiatives that we have done. It doesn't mean that your collaborative has done it. You don't have to do them. They're just the ones that we have done based off the gaps that we have found in our community. And one of those is our senior story time. So every third Wednesday of the month, our seniors and our kids come together and they do stories and crafts. It really started off as just an idea that that I was like, you know, this would be really great because there's a lot of so that was one of the things that a lot of parents were saying is that we really want to see a lot of intergenerational things. I'm like, okay, how can we make this happen? So I sat down with Heather, who is our senior center activities coordinator, and I said, okay, this is my idea. What do you think? And she's new to her job, and she's like, yes. I'm like, all right, this is a lot easier than I thought. And so we decided let's make it consistent because consistency is key, especially when you're talking with kids. So that way it's easier to remember. And it started off really small, honestly. I'll be really honest with you. We honestly thought it was going to be a dud because the first couple, it was just me and my kids and one senior. So we were really, we were really taking one for the team and just, you know, being the sole participants there. But just to kind of put it in perspective, we just had one yesterday. Our monthly story time was yesterday and it was all about ice cream. We read stories about ice cream and we made ice cream in a bag afterwards and we had 20 people there. So it can grow and it takes just a little bit of time and a little bit of consistency and word of mouth and for people to understand what it is and for the, you know, the things to be out there. And some really great things have happened from it as far as we have a senior that makes blankets for our kids. And so if there's a new mom in the area, the new mom will get a nice little quilted blanket as well as a pack of diapers and a pack of wipes. She also this last story time made some pillowcases for everyone to take home. So she handmade all these pillowcases, which I wasn't even prepared for. She just brought them. I was like, this is great. And it was something that was really special because all the kids just felt like $1 million because someone cared enough that to make a blanket. Both of my seniors also have done different trips and they find it so, you know, impactful in their life that they actually brought back books from their trip. So the one senior went to Canada and she specifically brought back an ABC book from Canada and we made our whole story time about Canada and she told the kids about their trip and she brought back Canadian money and showed them where Canada was on the map. And it was just really great because not every kid gets that experience. They might not ever go to Canada. And our last one, she just went to Norway. So she brought back Norway books so that we could share them with the kids. So I know that obviously every community is different. And so what happens in our community might not work for yours, but it is a really great opportunity, especially like I said, for not just to help with the seniors, but for the kids, because they get that interaction and they put it on the calendar every month, which is really great. And they're like, you know, we're going to schedule our time. We're going to make sure that we get there. And so it's just become a really consistent, great thing. So that's one of my favorites because, you know, it just has really grown so much. Another thing that we do with the hospitals actually is called Reach Out and Read. Have you ever heard of Reach Out and Read? So it's actually a national evidence-based reading model. And what we do is that we will do different books and things like that in the doctor's offices. If you want to be a part of it, that's what the link is for. It's Reach Out and Read Michigan.org for more information how to get involved. It's really trying to get that strong parent-child bond through reading. So it's again, just another strategy that we do that we try to incorporate with the healthcare offices. I tried to make my presentation more around that rather than just our story times and stuff, so you understand that different ways of how you can get involved with your Great Start Collaboratives. We also do book nooks. So the book nooks are something similar, but so like let's say you're at the dentist or at the doctor's and your kid's going absolutely crazy. Well, we have book nooks there that we have supplied. We have 9 currently throughout the community, whether it's through Delta or Schoolcraft. And they're just child-sized books that way it's just something for the kids to do, and so that way they're not, you know, running around and you want to pull out your hair kind of thing. And it's all different books about like diversity and celebrating students with different needs in their book nooks. We also have some extra that we recently have put into the hair salons, and we also supplied hair salons with like little capes that they can use for the kids too, just to make them feel a little more comfortable. You know, with the haircuts, but that's also kind of a little bit of an intimidating thing. So another thing that we did, and I actually brought some just in case you guys want to see them, as a busy book. So this is another thing that if you're in a doctor's office or the kids are just needing something for a little bit of a quiet time, our parent members actually put these together, and they're supposed to be, you know, a nice screen-free activity to do. And they have just like all these nice little things in there, like let's talk about colors and like, you know, just things to kind of get like, let's sing and just get kids' minds off of being bored or, you know, creating too much craziness in the offices. And it goes on, and they can write, they can color, there's songs, there's little poems. So they're a really nice thing that you can definitely use if you ever need them. Like I said, I brought a couple. I brought a couple of resources, so that way if you guys want them, you can take them back to your home base and see if you can use them. The other things that we have done is the blankets in the ER. So we've donated over 200 children's blankets to the OSF hospital in Escanaba as well as Schoolcraft. And they're just as like a little safety blanket for them. So that way, if there's a kid, you know, a little bit, it's scary in the ER, a little bit distressing and everything. So just something for them to feel a little bit comfortable about. As you can see, that was us dropping them off at OSF. So we're going to be dropping them off in Schoolcraft this in September. So it's just a nice little thing that there's just, you know, little things make the difference. So the next thing is Help Me Grow. Has anyone heard of Help Me Grow? Before I go on to the spiel of Help Me Grow. Okay, so when she was kind of talking about resources, it might in a way kind of go with Help Me Grow. So I brought a bunch of these too. So Help Me Grow, so that if a parent ever has any questions, whether it's the child's development or they're trying to find something, they can contact Help Me Grow at that 844 number. And what they're going to do is that local call, that coordinator will then, you know, they'll get the call, then they'll get the whatever resource that they're trying to find. So if it's a dentist or diapers or a playgroup, whatever the parent is searching for, they'll find that resource for the family, and then they will then follow up with the family saying like, hey, this is the resource. You know, we found it here, and then they make like about a week go by, and then they follow up with the family again, basically saying like, hey, did you get everything? Like, are you good? Just to make sure that the family has everything that they need. So it could be anything from like your basic needs, healthcare, home visiting, early on, really anything that you could possibly need. And it's a national system for supports with young children. So it's not just a Delta Schoolcraft thing, it's a national thing. We actually right now are part of a pilot, and it's just that central point. So that way they have all the resources and anything that they could possibly have. Because again, when you're whether you're a new parent or, you know, you're a veteran parent, you're still looking for some sort of resource for your child. I know I still am. So it's a really great thing. And that's what the next slide is as well, is it kind of goes over as far as like what the difference between early on, and this is actually specifically made for physicians, and then build up and Help Me Grow. So actually, like she said, you'll have the access to the slides, but it's a lot of good information as far as like what the difference is, and maybe when you can maybe refer them to Help Me Grow, because you can also refer them to Help Me Grow just so that the parents do have that central point. And that way they're feel a little more confident with the resources that they have available to them. So a lot of questions that I get to is like, how can I get involved with everything? So depending on, again, your your collaborative and what they do. We have a meeting 4 times a year that we get all the different organizations, whether it's a hospital, LMAS. Sometimes it's United Way, depends on who's there, that we get all together and say, hey, like what's happening, so that they can report out and they can get the number of families they're working with and kind of just tell us what they're seeing in the community. So then we can then take that back to our families and kind of work with what we want to do. We also do an action agenda meeting, and that was where we plan our activities and different initiatives to support families. That link there will actually find your local Great Start Collaborative and connect you with your family liaison or director. So like I said, there's a director and there's a family liaison in every county. So if you are looking to get connected with them, that will take you there, or you can reach out to me and I can probably figure out who it is, because we all know each other. So if you're kind of like, hey, this sounds pretty interesting, and I have to wonder how I can get involved with them, I can either help you, or you can also just find them there at that link as well. And that's where our meetings are. And then we also, like, I do a meeting with my parents every month, as far as we all get together, we do free childcare and we do free dinner. And we just talk about like what they're seeing in the community. One of the main things right now is school readiness. So we just talk about whatever is on their mind. It's like a safe spot for all the parents to go. So yeah, does anyone have any questions?
I mean, as I shared when, during your introduction, it's just a wealth of information that, does everybody know of the Great Start Coalition in your
Yeah.
area?
I've
We
got
have
lots
something
of,
similar in school now.
Okay,
lots of resources.
I think it's
We have
0 to
8
5.
now, But
Do you know what county are you in?
not common.
Yeah, I said every county should have someone like me. I mean, off the top of my head, I don't know who it is.
Right.
I know more of like the UP liaisons because that's who I work with. But every county should have someone from Great Start or someone like me. Like I said, I know it gets confusing because there are so many starts in the community, like Head Start and everything. And so I know like we get confused a lot for Head Start, for Great Start to Quality. Just the other day, someone was asking me about free pre-K, and I'm like, I can answer that question, but it's not my forte. Because it's just not our group. Like I said, we're all kind of interconnected and we all have that little bit of overlap with what we do, but it's not us.
Who would I contact right now?
So that link
Yeah,
right there, well, if you go to that link, it takes you to exactly, it shows you county by county. It has who the liaisons are and it has who the directors are, because it's always changing. Because sometimes, people leave, so whenever they leave, they update that contact list. And so if you're looking for them, that would be the link to go. So if you look at like Great Start Collaborative, it will take you there, and that's the specific spot that will actually take you to where who your person would be. I said off the top of my head, I don't know. I met a lot of them this last couple months ago we had a convening together, and I'm really good with faces. I'm not really great with names. So I probably would see the face. I'm like, yeah, yes, I know you, but I have a very hard time with names, I'll be honest. So yeah.
awesome.
You're not concerned about like the funding coming from the state of Michigan with this program at this time?
Not at this time. No, we're not concerned about the funding. I've asked, and that's not a concern as of
Okay.
yet. So that's a relief. A lot of our funding is grants. We do like a lot of, like a 32P6 is what our funding is for our literacy grant. That's the one that's a little bit in jeopardy. But there's other avenues that we can take and
Yeah.
yeah, and kind of go that avenue instead of going for the 32P6.
Okay.
And there's also some other funding that's up in the air that we won't be impacted, but your other Great Starts might be, because they're trying to pass some sort of funding where they are taking the funds and they're going to take them directly to the ISDs instead of the funds going to the Great Start programs.
Okay.
So that the ISDs are then in charge of distributing that money appropriately. And if your ISD doesn't really care about early childhood education or the early childhood in general, it might be swept under the rug, and the Great Start Collaboratives might not get as much funding as what they are currently. So I can't promise all of them. I mean, I know that we're not too concerned because of where we're at. We're in a good spot with our ISD. But that's not to say that other Great Start Collaboratives might not be impacted.
Okay.
So it's a possibility.
Any questions from any of the folks online?
I do have a question. So a lot of questions I get from parents is what activities are available in our area for them to take their
Mhm.
young kids to do? Would this be somewhere I could refer them to keep a track of groups or any activities going on?
Yes, so like, I brought a couple of different things, that way, if you wanna take one before you guys leave, you definitely can. So like what we do is that we have like something like this where it tells like who we are, because sometimes it's a little bit intimidating as a new, like as a parent, of like, oh, I don't know if I wanna be, involved in that, so it kind of tells them like, this is a really fun space for you, and it's for you guys to connect. We also do a newsletter, which is in here, and that newsletter has all the different activities, depending on your coalition, they might either do a newsletter, they might do a calendar of events. But all the Great Starts usually also have a Facebook page, and they also will post their events on the Facebook page, so like we have a Facebook page, like all the events are on there. Definitely send them to Great Start, Collaborative, also the Family Coalition, because I know they're always looking for members, and they're always looking for new families to be heard. So it's definitely the spot. That's basically like the main question that I get to is like, what's happening in this community? Like, what can I do with my kids? Like, when you live in the middle of nowhere, you're like, guess we're gonna go outside again, So that's a really good spot, because different collaboratives, they'll do play groups, so you can get together and you don't have to talk to a toddler all day. You can actually talk to other parents, which is really great. They will do reading, they'll do story times, so we will do story times. We do music and movement, I do it with my mom. So the music and movement is just a time for the kids to, get together and they learn through song. So depending again on your collaborative and what they do, it might look a little bit different than what I just talked about today, but it's gonna have that same concept, because all the collaboratives have the same initiatives and the same things that we're trying to see. But I know that a lot of them do the play groups. That's a big one that parents are wanting, because they just are really wanting that connection, and the kids need the connection too. They need that social side, they need to get ready for school, and that's one of the things that we're trying to look for, is that school readiness. So definitely point them in that way, for sure. Mhm.
Anybody online, have any questions or an experience that they want to share, with their, Great Start Collaborative? Okay, quiet bunch online today. Well, thank you for
Maybe
coming.
I just answered all the questions.
Thank you for coming, Monica. We really appreciate it.
Yes,
I
thank you
know
for
it was a
asking me.
long drive for
Well,
you.
Hey, it's all right.
And
My dad drove, so he was my chauffeur.
Thanks, Dad.
He just wanted to come to the casino, didn't he?
Yeah, right. It was promotive. I think it was for the coffee, so.
Well, we appreciate you coming down and sharing, the great work that you're doing. As Monica indicated, these will go out. So if you are interested in contacting your collaborative in your area, make sure you visit that link and see what's available. I think having enough resources is always a challenge in our rural clinics. So check it out. Thank
Always
you.
looking for me. I'll leave this stuff over there.
Thank you.
So that.
Sounds good. Thank you so much. Appreciate it.
Thank you. No, not me.
Always.
Laura, are you being naughty? We have to put you in the corner. Awesome. Well, next it's me. I am so excited to share this. We have been working diligently on some diabetic work, as you know, from the year perspective, as we look to support diabetes in our clinics. One of the opportunities that we have had is to work with Anjanette, and you'll hear from her next, from MDHHS, and we've had the opportunity to focus in on diabetes from two different realms. One from the echo phase. We've been hosting monthly echo sessions with some providers from a few different clinics, and really giving opportunity for those providers to connect with another physician who has specialized in diabetes care. They've been well attended. I've just been amazed at the information that has been shared with those within those echoes. But additionally, we've been able to put together a collaborative that brings a couple of the clinics together and some of the staff and some of the providers to focus on diabetic retinopathy screening. I think that it's always a challenge to get your patients to go and get their diabetic retinopathy screening. We know it's a gap in care that needs to be closed. We know insurance payers push for this. We know it's best for the patients, et cetera. So today I'm really going to share what we've been doing to develop a diabetic retinopathy toolkit. So just workflow processes that you can implement within your clinic. That's in a PDF form. We'll put it on our website and share all the resources with this. So I'm really happy to share it. It's not quite finished, the file itself, but I've taken all the information off of our toolkit and put it in a slide deck. So first and foremost, why does this matter? We know diabetic retinopathy is one of the leading causes of blindness in the United States. And our screening rates, as Anjanette will share within her slide deck, are not the best. You know, it's one of the times where we don't want to be at the top of the list. And we have work to do when it comes to diabetic retinopathy. The disease often progresses without noticeable symptoms until late stages. So your patients may say, I see fine, I don't have a problem. And unfortunately, by the time they realize they have a problem, oftentimes it is too late. That's why that screening is so important, and so important for our providers to be able to really work with our patient populations and have best practices in place so we can get those patients in for the screenings that they desperately need. Of course, we know also improving the screening aligns with a lot of the clinical quality measures that I just mentioned, but it really impacts the quality of life for our patients. So we want to make sure that we have some tools and resources to be able to do that. So the American Diabetes Association screening recommendations, and these are recommendations I pulled right from there. Type 1, you need to screen within 5 years of diagnosis. Type 2, screen at diagnosis. Frequency every 1 to 2 years if there's no retinopathy, and then annually or more frequently if retinopathy is present. And then also, I put this in here, pregnancy eye exam before or during pregnancy and follow-up postpartum. Those are the recommended times. Of course, depending on each patient, it can vary a little bit on what their provider recommends, but ultimately, we want to try to adhere to those recommendations, specifically for patient outcomes, but also for those payer aspects. So setting the foundation in your clinic, in terms of roles and responsibilities before implementing new tools and processes, is to make sure there's someone who's really in charge of making sure those diabetic retinopathy screenings are handled. Whether it's your referral person who's tracking that, is it on a dashboard, who manages the referrals, who follows up if the patient doesn't go and get that and they remain on this list. Without some of those clarity, some of those things really fall apart. If nobody's owning it, typically then it's not happening. Success is really defined as a team role, from the front desk individual to the MA who's rooming the patient, to the referral individual, to the provider, and sometimes even the practice managers. You know, you're the ones that are responsible for pushing that information out to your providers and making sure some of these quality gaps are closed. So you want to have a written workflow plan. You want to address those barriers such as cost, transportation, language, and scheduling, which we'll go into a couple tips there. And then, of course, track by demographics to spot some of those disparities and really use that data or that information you have out of your EHR to be able to hone in on those patients that we need to get in for their exam. So this is just kind of a screening workflow overview. Of course, identifying your patients, making those referrals. One area that I think we all can do a little bit more work in is strengthening your provider connections, reduce some of the barriers for your patients. Ideally, pie in the sky, I would love to be able to get cameras into some of the clinics, especially those clinics that really are ready for them, and they just don't have the funding. And then, of course, using that data to stay on track. So identifying your patient, some of the best practices around identifying your patient, of course, is using your EHR alerts, things that are automatically set up in your EHR to let you know when that patient is in, that they are due for their diabetic retinopathy exam. Also your care gaps reports that you get from your insurance payers, working those lists and understanding which patients still have yet to have their diabetic retinopathy exam done. Chart prep is another great piece that you can use if you don't have a chart prep process within your clinic. Doing that chart prep process and understanding every patient that's coming in, what they're due for. Obviously, diabetic retinopathy screening is just one. whether it's a foot exam for diabetes, or it's your colonoscopy, or it's your mammogram. Understanding and knowing what your patient is due for during that chart prep process is an excellent opportunity to identify those things. Another opportunity for your patients to get all the things they need is engaging in the CCM programs. So if you have chronic care management already in your clinic, make sure that you're leveraging your CCM managers to ensure that they are including diabetic retinopathy screening within that process that they use to manage their patients. And then, of course, education during visits. There are a lot of resources that we'll be sharing not only within our toolkit, but also that Anjanette will share. There's a ton of resources out there to educate your patients. Yes, ma'am.
That is the biggest issue with retinal eye exams, coming from a quality background, is educating the patient.
Yeah.
Because they don't understand the difference between
An eye exam.
an eye exam and a retinal eye exam. So, some are going to optometrists, some are going to an ophthalmologist, some are just saying, well, I don't know, my doctor just told me to come here and get my eyes checked. So they're just doing a vision check and not doing it for retinopathy.
Yeah.
Or they're going to Walmart and then Walmart's not sending us the reports back. They might have gone, but we're not getting them back.
And that's.
So there's so much education behind a retinal eye exam.
And that's the most important part. And we've actually kind of toyed within the collaborative that we're working in is, what kind of systems can we put in place? And one of the ideas we had is taking a little postcard and giving a postcard of information, one, to identify the patient, to say, you're due for this, here's your reminder, but also that postcard can go along with them to their optometrist, to their ophthalmologist, whoever it is. And on that postcard, you'll have information where that report needs to be returned.
Or
So it's
letting
having
your-
that closed loop.
the eye doctor know you are a diabetic, so you
Yes,
need
that
the
you're
retinal
diabetic.
exam. They just don't think they need to know that information.
Right.
We
Yes.
talked about that a lot in our collaborative.
So, these tools and these kind of resources is what we'll be building in. So when you click on or you get the PDF of the toolkit, you'll be able to click and find some of these resources. So as we work with Laura's one of the clinics, as we work with Anjanette, as we work with the resources that are out there, pulling all this together and making it available for all of you is really what our goal is. I don't know how many times I've had clinics tell me, it's not that we don't want to do quality work. It's not that we don't want to care for our patients. We often don't have times to go out and find all of these resources. So our goal is to be able to put this in a nice, neat little package and deliver it to you to make that available. So if there's things that we miss in this, this is a tool for everyone. It's going to be evolving. We're going to keep it on our website. We'll have that PDF file that people can download and have all the resources consecutively. But ultimately, this is your resource book. This is your toolkit. We want to design it for you and we want your feedback.
Leanne from the chat says, do you have an example of postcard? That sounds like a great idea.
No, but I'm developing one. It's on my to-do list. And that really came out of conversation with the clinics we have, because as we talk with the clinics, what we've heard is that's the number one challenge. It's not that they're not getting referred to their diabetic retinopathy exam. It's not that they're not identified by your EHR. It's that they're told to go, and that's where it stops. So
Or their insurance won't cover it.
and their insurance won't cover it. I mean, and there's a lot of misconceptions on the patient's portion. So how can we identify that with the patient? How can we educate them? What tools can we put into place to give that to the patient? The patient goes and gets the exam done, and then the information comes back. So
Like, they don't understand that once they're diabetic, it goes to their insurance, not their vision.
Right, right.
Goes to their
That needs to be
insurance.
educated.
yes.
That could be something good for the postcard. If you
To
have
to alert the
diabetes,
optometrist or
your
if they go to an
exams.
ophthalmologist, they're
Yeah.
gonna recognize
Yeah,
it.
Right,
Yeah.
but I actually have heard, because I work with the Michigan Optometric Association, that sometimes it's just, if they're getting their vision exam, they just charge for the vision exam and they don't go the next step and bill their medical insurance.
Mhm.
Right.
So then that
So
code's not going over.
Right.
And
Right.
they have to ask for that specific card, because if they don't have it, and they
Right.
don't have the medical insurance information, they don't know where to even begin to look to verify that information.
Yeah, because I've heard, well, I just had it done, 6 months ago. Oh, really?
And then you read the report and you're like, there is nothing on there.
Right.
Yep,
Or if you even
that
did it.
indicates the retinal exam was completed.
So the very first step, of course, is just making sure that you can identify the patients who need that exam and getting that referral done. And then that education. And again, this toolkit will have some of those resources. Anjanette from MTHHS has been fantastic at sharing what is available to her. But also there's a number of websites out there that some of the folks that will be speaking later today have identified as well. So the next thing, of course, is making the referral simple. Use your EHR when possible, standardize that documentation and follow-up. Of course, have a process in place. So you have someone in your clinic that does follow up when a patient doesn't get that done. And I know that's resource intensive. But again, if we don't have a process in place, your patients are going to end up not getting it done, plain and simple. Assign that referral person, that management, to a team member that can continually have that on their to-do list. And then most importantly is build some of those scheduling or some of those relationships with the eye care providers in your community. Help them understand what you're trying to do with your diabetic population, that you really do need those reports back, that they need to know that you're sending your patient who is a diabetic patient to them to have that screening done. So we want to make sure that we're building out that relationship and that we're ensuring that referral process and that return process is happening. So next, building some of those strong community relations, again, knowing your local providers, but where are they at? What kind of insurance do they take? Just like the dental, we need to understand what our providers in the community have and don't have, and what can they offer and don't offer to our patient population that we're sending. So knowing if they can do the dilated eye exams, knowing if they accept Medicaid. A lot of our patients are Medicare, but a lot of our patients are Medicaid that we're sending off for diabetic retinopathy exams as well. And then, of course, defining that follow-up process. Create some internal maps and patient handouts. Again, having that available so you can give your patient, here's where the optometrists are in our county. And we know it's not always just our community or our town, because sometimes there's not one in our towns. And we may have to broaden that, that map out into the county space or to 25 miles around to be able to find that provider. But if you have something to hand your patient, it's just that one step closer for that patient to get to that ophthalmologist or optometrist and then get their eye exam done. And then also provide scripts for your staff. When you talk about education to the patient, sometimes it's hard for our staff to know exactly what to say that will motivate the patient to get this done. So providing a script or providing your staff some training to be able to understand what is the best approach to a patient and helping them make sure they understand the importance of a diabetic retinopathy screening. So provide some of those scripts, provide that postcard, have those additional resources available for your patients to be able to communicate to the patient and to give to the patient. Again, reduce barriers, cost and coverage guidance. Patients often don't screen because of the barriers of the clinic. Outside of the clinic walls, they may not be able to have transportation. They may not have the money to go and get an eye exam done if they think it's just an eye exam. So help them understand what the financial aspect is of getting the diabetic retinopathy screening done. If there's transportation services available based on their insurance, help them identify what that is. If there's low literacy or multi-language materials that you need to provide with your patient population, your population best. If there's Spanish speaking or low literacy, make sure your materials are within the reach of the patient so they can understand what they need to do. Again, that care coordination support is really paramount. I know a lot of our clinics have really invested a lot of time and money into their chronic care management program. Excuse me. Help them, again, gain the tools and the resources that your patients need. And then one thing that I think is really important, and it's a task within our office that we want to do, is all of your insurance payers, what do they offer as an incentive? Not only as a closing the gap in care, but do they offer an incentive for the patient to go and get the diabetic retinopathy screening done? And I know there's insurance payers that pay from $25 to $100 to get that retinopathy screening done, and that goes to the patient. So that's a huge incentive for our patients to go and get that done. So understand what those are, look at your payers. Again, it's something we're hoping to include. I mean, it'll take some resources out of our office to get that entire list done. But if you're aware of it, excuse me, send it our way. We'd be happy to include that in the cool toolkit that we're developing. Not see anything else on that. So in clinic screenings, does anybody online or in here, which I know I have a small group, have a retina view camera or a camera in their office that they use for screening? Just throw
We
it
do,
in.
and we do.
That's Tammy. Oh, you do, Tammy?
We do, but we actually had this discussion today at a staff meeting. They do not love it because the quality is not the greatest.
Okay,
And sometimes it's hard to get a good read. And of course, there's certain factors that make it more difficult for certain patients, like if they're on certain medications and different things like that. So,
in terms of the positives, I mean, are you getting screens that are positive where you can then get them over to an optometrist or an ophthalmologist as just that initial screening?
well, I mean, we have an ophthalmologist that does review them, so we actually just kind of transitioned because we had one leave and we just started one. So we actually had to put them on hold for a minute because they have to be interpreted and read by an ophthalmologist. Um, so there's that piece of it. So if you don't have somebody to interpret them or read them, there's that problem as far as from a billing standpoint.
Okay,
But we do have one, so we're able to start doing them again. I just find that they're not using them as frequently because the quality of the images are not as good as, and they're not getting good reads. So then they're having to try to get them. Because we have an in-house ophthalmologist at our facility, we try to encourage them to go that route if they can because it's just better and more accurate, though.
okay. So those of you who do have them, as we roll this out, we'd love to investigate more. And it's again, part of the collaborative that we're doing is to understand more about what the opportunities are for piloting a retina view camera within the clinic. How can we replicate that? How can we get the right camera in? What are the protocols that need to happen? So clinics that are in a very remote area can utilize that at minimum as that initial screen. And then if it screens positive, that the patient can go and follow up with an ophthalmologist or an optometrist to ensure what the screening showed is truly accurate. So again, in clinic screenings, if there's a fundus camera during the routine visit, capitalizing on that, Tammy, if that's something that you need help with from our perspective, we're happy to potentially get some other clinics who are doing it and help resolve some of the problems. Obviously, there's staff training. There's standing orders that need to happen that automatically have standing orders so the patients can automatically go through that process and that immediate documentation.
Yeah, the feedback I got today was if the quality was better, they would actually probably try to use it more than they do because they do think it's a great tool to be able to do it in the office to ensure that they're capturing that for those patients that you may not otherwise capture.
Is this a new machine, Tammy?
Yeah, is it new or what brand is it, Tammy?
I think it's Retina View,
Okay,
and it was here before I came, so I know they've had them for a few years.
okay.
And we have several offices that have them, and that's kind of the general consensus for all of the clinics. It's not just like one clinic or one piece of equipment. It's just that the imaging isn't as great as they'd like it to be. And again, sometimes just trying to even get, because it's very sensitive as far as if it doesn't line up just so, it won't do a good read for them at all. And they're like spending a lot of time trying to get it to do what it needs to do. And it's not doing what they want it to do. So if they can get them to go to an ophthalmologist, that's what they prefer to do.
Preferences. Okay. So is the feedback on the quality of the screening from an ophthalmologist or an optometrist, or is it from your provider?
Both.
Okay. Yeah, it'd be interesting to know, when in your copious spare time, understand what year or what brand, or model the camera is.
Mhm.
It'd be nice to do a little bit of investigative work on our end to say,
Yeah.
what does that look like? Is there updates or, trade-in policies? I don't know, what's possible.
Yeah. Yeah, and I know, that would be definitely helpful to know. And I know, like, for you said optometrist, I know part of the problem with billing is originally they started with optometrists reading it and they weren't able to bill for it, so it had to be an ophthalmologist, just an FYI.
Good to know.
So,
Good to know. So of course, one of the other things that we like to recommend is using your data to stay on track. Run those EMR dashboard reports. Verify your coding accuracy, such your CMS 131 and your HEDIS measures. Backcode missed screenings. So if there's missed screenings, make sure that you're going in and backcoding them. Audit your charts, so we understand which ones are actually getting missed. And then track referral follow through, and then share progress with staff. So again, like with any project, knowing that you're making progress is always an incentive for staff to be able to continue that good work. So when you see your numbers go up or you see that improvement progress happening, it's always incentive for the patients to be able to do so. One other component that we'd like to be able to include in the toolkit is some PDS cycles for continuous improvement. So those of you who do like to use PDS cycles, which is just that plan of a small test of change that you're able to plan, do, study, act. We'll have some of those samples built within. Examples include things like chart prep. Are you doing chart prep consistently? Okay, we have some giggles in the room because there's this funny noise.
It's music.
Oh, it's the music.
It just
That's
came
what
on
it is.
randomly.
It's coming on randomly, so sorry about that. Now we have our sound guy in here. Oh, thank you.
See that?
Yeah.
Yes,
That
thank
was
you.
it.
We appreciate that. So for everybody who's
Just had to be
online
one.
virtually, we just had this weird sound happening and it was music over that just suddenly popped on. So PDSA cycles for continuous improvement, some of the examples that you could do are chart prep, referral for the scripts, and then follow up and tracking. You can always put in place a PDSA to be able to track that progress and know where your improvement areas could be. And then regular check-ins and visual trackers are always helpful as well. So quick wins to start with regards to diabetic retinopathy, train your staff to flag patients during the chart prep, run that baseline EHR report, understand where you're at with your population. I think you might be surprised if you ran just a report on how many of your patients are diabetic and how many have actually had a screening. Build that one strong referral relationship, find that community provider that's either the ophthalmologist or optometrist that's going to work with you, that's going to work to be able to communicate back and forth, that are going to take care of your patients and that are going to send reports back. Use those standing orders where appropriate, and then act on the same day if possible if you have that screening capability right within your practice. So we'll have some tools and templates that'll be available. We're looking at referral tracking logs, patient handouts in English and in Spanish. Of course, we're looking at the little postcard development, standard order templates, and then EHR tips for Epic and Cerner are the two that we're focused on initially. But we'd love to be able to build those out as we encounter other clinics that are really focused in on your diabetic retinopathy screening, to build out some of those tip sheets per EMR. So we know, unfortunately, our EMRs are always the nemesis and sometimes one of the biggest challenges that we have to work through. So again, just starting with small steps, you don't have to tackle everything at one time. It could be something as simple as developing that postcard or using that within your clinic. It could be just making sure that your alerts and your system and your EHR is working appropriately, and you've maximized everything you can use out of your EHR. Everything that helps get your patients in for your screening is going to be a win. So first and foremost, also, I want to make sure that we recognize the RHCs that are participating in this collaborative, which we appreciate because it does create some extra work for them. But hopefully they'll be able to see some good results that we'll be able to share at one of our next meetings. And then MDHHS for allowing us to work with them on this project and really funding the project so we're able to do some of this dedicated work, not only in primary care, but RHCs. So we appreciate that. And that's all I have. Does anybody have any questions?
Yeah, I was looking into the vision test, so I'd be curious for Tammy to tell me what brand and all that it is.
Well, and that'll be helpful because right now, we are having conversation with a couple of our different Medicaid providers, our HMO providers. And they have what they call community reinvestment dollars. Where they would be potentially interested in funding a couple cameras. Obviously, you know, we would put it in a clinic, specific in our RHC clinic. We'd love to pilot something like this so we can understand, one, the quality of the camera in the screening process. What does that look for protocol? What does that look like for standing orders? How can we make this something that's accessible for other clinics to do, but really be able to refine the process? So if a clinic does want to engage in a trial or in a camera, then we can provide some of those resources to really make that a little bit easier for them
But I didn't realize it had to be read by an ophthalmologist.
to be paid for it. Yes.
That's the trick.
We never know
That's
what
a- that's a
possibilities are
barrier.
out there.
It's a barrier
Yes.
that needs to be changed.
Oh, you mean when you use one of the cameras? Usually when you sign up, they will have an ophthalmologist, if you go through one of those, you can have it read by somebody off-site, like you don't have to have one on staff. And then there's like a fee you do with, who's your PO, your physician organization? You have to
Zip up, yeah.
They've done this before, you could reach out to your contact.
So how many actually track their diabetic retinopathy screenings that are done or not done?
If you're online, you can raise your hand too if you don't want to unmute or put anything in the chat.
I mean, is this common? Are clinics doing this? I mean, I'd love to be able to share that with Anjanette, who's in the room. How many are actually tracking your DR screenings, either done or not done? You guys do? So everyone here in the room does.
Marcia Nemeth does, Brittany Holly,
Yeah, she's on.
Leanne, Corinne, Christina.
How many feel like they could use some tools or some resources to help with that process? Just put a yes in the chat for me. If you feel like there's tools or resources that would be helpful.
We're getting yeses.
That's the issue, yes.
Do resources include extra bodies, like FTEs?
No, I don't these. But we can provide resources
I
to
know.
cut down some of the legwork for all of you.
Yeah.
So if one of those items really sound particularly interesting to you, I'll put that on my priority list. You know, if it's the postcard and I can disseminate that,
Yeah,
I'll get her out.
I like the postcard idea.
Are you gonna work on creating the optometrist list for each local area, like in the county? That would be really resourceful.
Well, for the collaboratives, those will be our first areas of interest. So for those of you who are online, Laura had asked, you know, if we could work on like a county area of optometrists and ophthalmologists.
And
So
what insurances they take, are they accepting new patients? I mean, those kind of little nuances. So
That would be
hit the ground, so we're
very
not
helpful.
taking time to do that, because I could assign it to an employee.
And provide them the cards also, because how many patients get there and say, oh, I'm supposed to bring my card.
Yeah, and just drop off a pile of those cards.
Yeah.
Curious if, and this answer can be absolutely like, that would not be helpful, but would it be helpful for like, I'm Sarah, to provide a message that you guys could use to reach out to those offices? Like, hey, this is what we're trying to do, just like to make it easier so you don't.
like a templated letter that you can send to the providers in your area on your behalf to say, you know, we're focusing in our diabetic retinopathy screenings. We'll be sending patients your way. Here's how we could collaborate together and the best way to send information back to us.
It would work.
Mhm.
There's not that many.
Yeah.
When we were a smaller location, it wasn't as many, but now there's many more. Yeah.
Yeah, just a few comments from the chat. Nicole Whitaker says, DM eye exams are part of gap in care closure efforts. Pamela, Grosvenor said we will begin offering retinal screening tentatively late October with Luminetics Core. They use AI. Let's see. Happy to share our experience wonderful though, as this will be new for our teams. Tools and resources would be great. So lots of yeses around tools and resources.
Fantastic. So again, we're about 3/4 of the way through. I need to go through and actually, just so you all know where this came from. Again, it really started with the collaborative work, and then we just pulled some resources together. and have it about 3/4 of the way done, but everything needs to be verified. We'd like to build out specifics like the postcard, like the templates that you could send an ophthalmologist or an optometrist. Those would all be clickables. So we're really excited, but obviously you can take some of the key takeaways from the presentation, which will be sent out in terms of just high level information, but we're excited to be able to release it. It'll be in a PDF form as well as our website, which our little guru here in the room will make that come along. So if anybody has any questions or any suggestions of a resource that you would love to have, shoot me an email, put it in the chat. We'll capture it after this presentation.
Yeah, or put it in the eval.
Or put it in the eval, yes.
I
So,
think the difference,
Jill,
between explaining the
don't-
difference between the retinopathy and a diabetic retinopathy versus a regular vision
We
screen.
even talked about having the resources in the room, remember Anjanette, like having the big eyeball, I know we have some of them in all our clinics, I can't say I have them in every single clinic about like what the difference is, like when you, the effects of having diabetic retinopathy and that, yeah.
Yeah.
We all want something to read in those rooms.
You do it on the back of the door and you're just sitting there and it's like, oh, what's that about? And I'm
That's
like,
Yeah.
what we should think about,
Posters.
if there's funding,
so
Yeah.
posters or like actual models, are you thinking like?
I think posters are nice, models
Posters.
might be a little bit more on the expensive side, but I think having nice big posters of something that we can hand out to the RHCs is always nice to have.
It could also be on the other side of those cards.
Yes,
Yeah.
that's a great idea too. Look at
Just
that.
that,
Yeah,
on
very
the side
good.
of the card.
Because then they have it and then they can read it and it's a tangible
There you
piece and
go.
they've got to keep it.
Yeah.
I don't know,
Yeah.
clearly.
Rebecca Grits are clever.
Can you come set me down?
The guru.
So if anybody has any further questions, feel free to put it in the chat or send me an email.
And then
Appreciate
that's where the
everyone.
toolkit could be located in for patients to use as a resource.
And there is, a couple of websites that have some nice photos of like basic, eye conditions when they start happening. Like you might start to see black dots in your vision, night
Yeah.
vision halos.
That's
So it's just like little snippets.
They
that-
need to be recognizing
could
and when
be
they need to report it to their
recognizing.
provider, because
Right.
sometimes the providers are really like, this is what you need to be recognizing, but you too need to be responsible for your health as well.
So those could be good to add to the back
Yeah,
of a card
look
or
at that.
something.
I'm glad somebody
Yeah.
said something.
And I was just in the UP last week at a meeting and Upper Peninsula Health Plan was there. And they shared, they do have some incentives.
And isn't theirs $100?
Theirs is 100, but it includes A1C, eye exam, dental exam, and kidney.
I mean, that's a huge incentive. If a patient gets all those done, they get
Yeah.
$100.
And then they're incentivizing optometrists, which I thought was
That was
interesting.
the other
I
one.
had never
Oh,
heard
I've
that.
never heard of that either, not that it might exist, especially with the Medicare Advantage plans, I'm interested to look back and see what if they are offering.
I know they were doing MU though. Because they were taking my blood pressure and everything at the eye doctor. and I'm like, what are you doing?
Oh, yeah.
It's like.
Has
We're
her
doing
like,
this thing
sure?
called meaningful use. That was back, like 5, 6 years ago.
Okay,
And then
well,
I
let's,
had also sent
I
you.
think having a QR code would be, like, if you're talking on the back of the door or something, just. 'cause
Oh, yeah,
they'll
that
Scan
too.
it and it'll be on their phone.
So that is like the biggest cybersecurity risk too, is a QR code. I would just put that out there. They.
Sure. they'll kill me.
Just saying.
okay, we want to move on to our next
Sorry.
topic, just to keep things rolling, especially for those that are online. Next, of course, we have Anjanette Lauren. She's an RN. She's with MDHHS Diabetes and Kidney Unit. And she's going to walk through a lot of the resources related to CGM. So continuous glucose monitoring. Again, this is something that came out of the executive board to say this is a really important tool and resource that you have in your clinics. So we have got a focus session on CGM. I'll let her take it away.
Well, I'm gonna forewarn you that my presentation is nowhere near how nice yours was. At the state, we can't add a lot of like graphics,
Yes.
so it's a lot of.
Well, I have free
bullets
reign,
and-
man.
No, at least have to be the bridge.
And AI is my friend. Cause it comes up with some pretty good images.
Do not have.
You're awesome. And I
I've guidelines. She says I have guidelines.
And I feel like a lot of the actual processes, and we have a couple clinics here that are going to, my presentation a little more high level and some resources, but there's a couple of clinics here that can give you a lot more specifics. And I feel like a lot of the processes that Jill talked about with eye exams actually could apply very much to CGMs. Of course, I was gonna have everyone in the room stand up, right, because we've all been sitting, so if you're at home, you might need to stand up and just do a little wiggle dance. Or maybe, since we have the capability of people to raise their hand, I was just gonna ask, how many people, know someone with diabetes? I was gonna have everyone stand up, and I was assuming the whole room was standing up,
Yeah.
right, so everyone probably at home is standing up, but,
Feel free to raise your hand.
Right. How about, I know this is another question, but how many people know someone that's using a CGM?
Oh, a couple.
Okay, all right, a few, okay. Well, just to give you a little background, so here's our lovely mission here at MDHHS. Provides services, administers programs to improve the health and safety, prosperity of residents of the state of Michigan. Just to give you a little more background on our unit, so the diabetes and kidney unit, it sits within public health. So, when you think about the umbrella of MDHHS, sometimes it's confusing. People are like, oh, what can you do about that Medicaid policy? We work with Medicaid and we love to do that, and we love to inform them about what's going on with people across Michigan and all you that work boots on the ground and with people of Michigan. Fortunately, we are not Medicaid in our unit, but we work very closely with Medicaid. So we like to try to influence those policies when we can. We work a lot, so our diabetes initiatives, a lot of the work we do is driven from CDC. We get a lot of CDC funding, don't have a lot of state funding, unfortunately. So sometimes our initiatives are what's federally important, right? So that's kind of pushed down, but we like to also work very closely with like you all in the rural health clinics, and we've done a lot of work in FQHCs as well. We don't deliver programs, so a little bit different than when she was talking about dental earlier. We don't specifically deliver programs ourselves, but we work with community organizations, hospital systems to build programs, diabetes specific programs to deliver those to people. And I feel like that's more sustainable anyways, is if those programs are built and delivered by people locally. So diabetes prevention programs. I don't know if you've ever heard of DSMES. It's diabetes education, basically. We have over I think there's 62 programs in the state. So we have staff that support those programs. They do like annual meetings, they share resources, we do site visits for quality checks, things like that. So I'll bring up that at the end and show you where that resource is. All right, so just to give you a little bit of data, I don't have a lot of specific data. We do on our website though have a data page, if you want to say, that has more specific data around diabetes prevalence, very specific to counties. So if you're welcome to go to our website and look at that. This is national data, so 38 million people in the United States have diabetes. I just grabbed this one chart off of there, which is broke down by age. You can see at the top there, diagnosed diabetes, undiagnosed diabetes, and then total diabetes percentage. And the reason I felt this was important, so across the whole United States, 14% of the population, almost 15% has diabetes. But as you can see, the different age groups, and probably a lot of you in rural areas, because we know a lot of rural areas have aging populations. So those 65 and over, you can see the higher percentage of folks, and that's also true in Michigan. We're not quite that high. I have some Michigan data on the next slide, but I think I heard by 2030, people over the age of 65 will actually be, the number of people over 65 will be higher than 18-year-olds. We'll have a much more aging population than younger folks. And then we do see a lot of disparities in diabetes across race, education level. So across education level, look at my numbers here. Oops, sorry, went one slide ahead here. 13% of adults with less than a high school education were diagnosed with diabetes versus 9% of those with a high school education, and it drops to 6.9 if you have more than a high school education. So education level very much is reflective of diabetes, and we see those disparities, and then geographic areas. It's definitely higher in, non-metropolitan areas.
Is it just type 2?
These charts, I'm sorry, I didn't specify that. Thank you for saying that. This is adults, so it could be type 1 or type 2,
Okay.
but only the adult population, so 18 to 64 is this chart. And the reason it's up to 64 is because over 65 need Medicare. So this is our Medicaid data, and unfortunately at the state, we don't have access unless we get other organizations to share their data. We just have Medicaid claims data that we can look at. As far as type 1 and type 2, type 1 diabetes makes up about 5 to 10% of diabetes diagnoses. So this data is Medicaid claims data from 2020 to 2023. You can see it's fairly consistent as far as the percentage. We did have an increase in 2023. That's the latest data that we have. And this is out of a report that is on our website, and I'll share the website at the end of the presentation. Okay, so why a CGM? Why are continuous glucose monitors important, right? So all of you at home, everyone here, I want you to close your eyes. Think about a place in town that you visit all the time. It could be a restaurant, could be a grocery store that you go to. You just jump in the car, no GPS is needed because you go there all the time. So think about that drive. You know, you go down the road, you know which light you're gonna make a right, and then I make a left, I pull in the drive, right? If you had to do it like you're sitting right now with your eyes closed, does that make you more anxious that you would not be able to see the road ahead of you? Right? Think about that. I don't know where the cars are. I don't know where the potholes are. I don't know where the lights at I'm supposed to turn, even though I drive there all the time. I can't, it makes me a little more anxious when I think about doing that blinded. But think about our patients with diabetes, right? They're prescribed medications like insulin that can be unsafe. It can be risky. They eat meals, they skip meals, they do physical activity, they sit at their desk for their jobs. They drink different types of beverages. So many different things that happen through your day. And if they don't know what's happening with their blood sugar, they're basically making those decisions blinded. If someone's checking their blood sugar with a glucometer and they're poking their finger 1 time a day, 4 times a day, they're still only getting that snapshot, right? They're not getting that continuous. Not because of my job is diabetes near and dear to my heart, but my son has diabetes and he was diagnosed at the age of 9. So I recall not having a CGM in the beginning, because he's 29 now, but, and I remember the seizures in the middle of the night, and the only reason I remember hearing them was because his bedroom was above mine, and I could hear the bed shaking because he was having a diabetic seizure from a low blood sugar. So, I just think they're a godsend, right? People have all their technology that they drive around with and have it in their pockets. We should have CGMs on all people with diabetes. So as far as what a CGM is, it's a continuous glucose monitor. It's a wearable device. You can kind of see an example here in the picture. It gives real-time data, tracks your glucose. You can share it with providers. You can actually share it with family members. There's models where, you know, children or even an older adult, if they were having a risk of low blood sugars, and they could actually share it with a family member so they can kind of, you know, keep track of mom if she's living alone. Readings every 1 to 5 minutes, so almost 300 readings a day. So you think about that if you ask someone to poke their finger that many times. Reveals, like we said, all those responses, glucose responses to all the different activities and things we're doing. Every year around November, December, the ADA comes out with standards of care, and the standards of care is that all people with diabetes have CGMs. I did add a link here, so if you want to learn more just about what a CGM is and more details, this Danatech site is referred to in a lot of my resources here. They have a great website for CGMs if you're thinking about getting started. If you've never seen one, I was hoping to actually bring one, but I didn't.
I did
get into
bring
the
mine.
office. You did?
Yeah.
Awesome. Well, you could pass it around to who's in the room. That's awesome. So this is just a little bit of a, description, but you see that there's a transmitter and that sits above the skin. Some of the older models, the transmitter actually had a snap in, but I see you have the G7, which is all integrated now, which is nice. And then the sensor, you can see it just goes underneath the skin there. I kind of describe it if you've never seen one. It's almost like a tiny little straw. So people have misconceptions, kind of like an IV. When you start an IV, that needle goes in and puts that tiny little straw in your vein. This is very similar. So the needle is retracted. So there's nothing that stays in your arm that's pokey, right? Like a needle would be. So it just sits right within that interstitial fluid. So very soft. So we're passing one around the room. Sorry that we don't have one to show you at home. So CGMs in primary care, why do we think that this is really, is anyone on the phone or online or anyone here why you think it's important that we're introducing CGMs in primary care? Is there any thoughts?
I will say because it helps the patient monitor their blood pressure or their glucose better so they can make adjustments in what they do on a day-to-day basis.
Yes, much.
I think that are just even medication adjustments are appropriate medication prescriptions to the patients.
Yeah.
Their diets have greatly improved.
Yeah.
Or the potential to be off medications with being on CGM, right? Lower
Yeah.
cost to the patient overall and to the insurance companies.
Right, yeah, they can make those see those lifestyle changes, how they're impacting them. So yeah, great things. I just read an article actually yesterday that half of the people with type 1 diabetes and 90% of people with type 2 diabetes receive their care at primary care offices, not a specialist. There isn't enough endocrinologists to see all the people in the United States with diabetes. So
90%?
90% of people with type 2 are being seen, getting their diabetes care at their primary care providers.
Yeah. 'Cause
So
you don't
hence CGMs and
recommend
primary
to an
care,
endo.
right?
Yeah, and you don't go to an endo unless you're having a problem
Right.
managing it.
Right,
And then it takes a long time sometimes to get into one.
and an endocrinologist is seeing so many other conditions. They're seeing patients with thyroid problems, so
Yeah.
it's more than just diabetes, and there's just not enough of them.
Yeah.
I forget the last statistic I had read about that, but it was like, one endocrinologist to like 500 people they would have to, it was like some ridiculous, number, yeah. And it's becoming the standard of care, so the more we can start to educate, primary care docs and getting them feeling comfortable about prescribing them. And it's just all of those processes that Jill had pointed out with eye exams. There's gonna need to be processes that you all would, implement. The other thing is, as far as the landscape in rural areas, more people with diabetes, they're an aging
Mhm.
population, so you're going to see that. And, people are living longer, so I describe diabetes as, your pancreas is wearing out, right? It's kind of like you've got 200,000 miles on the engine of your car. Eventually, it's gonna kind of wear out. Our pancreas has done a lot of work over the years, and it's gonna start to wear out. Those beta cells are depleting, so longer people are living, their pancreas isn't as functioning as like it used to, so. There's the decreasing number of specialists, lack of transportation, so even if there are endocrinologists, do people have transportation to get there? Can they take time off of work? They may have other, social needs, babysitters and they have other responsibilities, so taking time to actually to make that trip somewhere. A lot of people don't trust larger health systems. We are seeing that and hearing that a lot. They like their community, they like to stay close to home. They don't necessarily want another doctor, so hence, primary care. So these are just some things to consider, and Jill had kind of pointed out some of these things even with eye exams. So there's opportunity for personal CGMs or professional CGMs. You would have to consider staff training and what support you all might need. So there's actually on the Dana Tech site that I was talking about, they actually have a practice readiness, kind of a checklist that you can kind of go through. You would have to consider billing, what parts of the CGM, downloading the information, reading it, all of those, how often can I bill for those codes? All of this information is in some of the resources that I have. Downloading and interpreting reports. I know the office that my son used to go to, they actually had an office dietitian, and the dietitian was the one who actually downloaded it, kind of interpreted it. The nurse looked at it, made recommendations to the doctor. Like a lot of that is part of their process. So that might be something you would have to consider, like who would that person be that would do those downloads? And then your practice workflows, identifying patients that might be eligible for a CGM. Michigan Medicaid covers type 1 diabetes, type 2 diabetes on insulin, diabetes in pregnancy. But there is prior auth for some of those. Type 2 diabetes still has a prior auth, but also what I've been learning is some of the MCOs are pulling back on some of their prior auth processes. So even though Medicaid fee-for-service has a prior auth, the MCO has the ability to do less. They can't add more, but they can do less. So some of them are pulling their prior auths back. Some of them, we found that 7 out of the 9 Medicaid MCOs offer it at a pharmacy, as a pharmacy benefit. So the fee-for-service Medicaid benefit is through the DME, where a person would get their equipment. 7 of the 9 MCOs are covering at a pharmacy. You might want to consider, so if there is processes for insurance, prior auths, who would do that and what does that look like? A lot of clinics will have a closer relationship with certain DME offices, so they know exactly what needs to be done, what chart needs to be sent. Their chart templates are also resources that are out there that's on some of the lists that I have. So if there's those very specific things that have to be charted, you're going to want to set those kind of templates up. And then patient needs, training, support. Back in the day when my son first got his equipment, we actually used to go to the provider office and the rep would come in from the pump company or the CGM company and sit down with a group of people. Now it's all online. But there's still a lot of the reps that will give you a lot of the support materials. And then, like I said, the 62 diabetes training and education services that are around our state, those are staffed with dietitians, nurses, and sometimes pharmacists. But I also have a map that you can look up where those locations are. So those are good support for you. If your patient is still contemplating the CGMs and the different brands, there's a lot of great resources out there that compare all the different models. So this might be something that you want to look at. These are just kind of, I would say, some of the top 4, I would say, that you see out there. And there's also a link to find and comparing those. This is a link here. It's to start a professional CGM program. So if you find that you think this would be something that would be easier for your office to implement, maybe you have a population that you're not seeing as many personal CGMs, but you really want to engage in the population that you have to wear one for a couple of weeks and be able to see that data so that you can make those medication adjustments, that you can talk to them about lifestyle. And they have 2 different models of these where it can be blinded numbers. So the patient does not see their data the whole time that they're wearing it, or they're unblinded. So there's different options out there. So this is a link to finding, starting a professional CGM program. So you would actually own the equipment in the office. These are basically a lot of the clinic resources that I kind of pulled out. So under that staff training and support, and then those practice and workflows. So I did not like clip pictures of all of them. There's a couple different websites, and I know that you guys had mentioned, using MCT2D for, CGM insurance coverage lookup. This website has a brand new one that's coming out. So there's a couple different options if you need to look up insurance coverage. There's billing and reimbursement resources. A lot of these, this website, Dana Tech, has a ton of training. It actually has a training section. So if you identify who's going to be your champions in your office, what kind of training that person would need, and they have different training for that. So the Panther program up top there, a ton of resources, both provider and patient facing resources. Kind of really breaking down what the report is that prints out from the CGM and explaining it to the patient in a very basic way. So they're understanding what they call time and range. If any of you aren't familiar with that, but there's a CGM 101 class. So that's a great one for your practice if you're getting started. So these are just some resources, and I didn't even put them all on here. These ones are very specific to the patient. So understanding the CGM metrics, so what the report means, all about time and range, finding and comparing those CGMs, a lot of affordability options. So if patients have co-pays, a lot, unfortunately, similar to other pharmaceutical companies, if a person's on Medicare or Medicaid, they don't qualify for a lot of the savings programs, unfortunately. But there is a lot of the CGM companies that will do free trials. So if a person wants to try it out, they can do that too. So I would say I did put the brand specific pages. So the Medtronic, Freestyle Libre, and then Dexcom. I definitely, all of their websites, you can reach out to the local rep, and they'd be glad to talk to you, help you. Is that where you got your, okay, so you will probably
Your
talk
Dexcom,
about that when you come
yeah.
up here and what
Closely
they've
with my
provided.
Dexcom rep.
Yeah, they're usually very helpful. And they usually have a ton of handouts and resources that you can share with patients as well. So no need to recreate anything. This is another one I know that some of the clinics that were here today, we're going to talk about the MCT2D. So this is a collaboration. I think there's many of the staff that's on this collaborative. It's the Michigan Collaborative for Type 2 Diabetes, are out of the University of Michigan. But they have brought together a collaborative community, not only clinicians, but patients, and then also clinics participate in this as well. But they're working to provide solutions and resources to promote equitable and evidence-based diabetes care. So they have a ton of resources if you're looking for patient resources. So that link is at the top there. They actually just came out, I think it was earlier this week, I had seen this mobile app, which is nice. I don't know if any of your offices have your docs use iPads, but they do a mobile app now. So if they wanted to like bring up a resource for a patient, they could do it right from their app. So they have a coverage checker, lots of handouts about healthy eating, just anything diabetes related. They have a huge resource library. And so this at the bottom here, the www.mich.gov/diabetes is our website at the Diabetes and Kidney Unit. We have a plethora of resources around diabetes prevention programs, diabetes education, chronic kidney disease. We do have a brand new page on diabetes technology. We have all the data, the Michigan data that's available for you to look at. One other thing we're doing at the state in our unit is we are working with our Medicaid quality team. So I don't know if you've seen anything yet on HEDIS or NCQA, but they are now making the diabetes, the CGM report that comes out. There's a report that comes off the CGM that can be submitted in place of an A1C. So if someone's wearing a CGM, they wouldn't have to go get their blood tested. They can actually, this report would qualify for the measure.
Yeah, that's true, but you have to have it built in your EMR to satisfy that measure too. It's
Okay.
something like we've known about for a year, but we've got to build it in our EMR to satisfy it.
Okay, yeah.
And when the build is built a certain way for it to be satisfied by a lab versus a CGM, it takes time.
Yeah,
Right.
okay, yeah, so something to figure out. We have been working with the quality team on a grant, at the state of Michigan, and so Michigan Medicaid is now going to have a CGM measure for their MCOs. This first year has been all around data collection, so hasn't really, there's no benchmarks that a plan has to meet, but the benchmarks are coming. So more to come, you probably will hear more about that, so there definitely will be some initiatives out there. I'm sure that we will work with the Medicaid team to make sure the health plan has resources that they can share with provider's office and things like that, so. Quality measure, I think it'll get a lot of, there'll be a lot of talk about that when it hits the ground running, so. So if you don't have a diabetes educator, in your office, or that you need support to help get training for patients, or they need education, you know, how does the CGM integrate with my meal planning and my physical activity? Please feel free to reach out to our website, or you can always reach out to me and I can make you connection to someone locally. But the diabetes services map, when you click on that link on our website, it takes you to an interactive map and it shows you all the dots on the map where all these education programs are located. If you just hover over the dot, it brings up the, phone numbers, names, all of that. So please feel free to visit our website for that. And I have my information if you need to contact me. I don't know if I have any specific questions or if we're going to turn it over to clinics to kind of talk about their
certainly,
experiences.
Yep, anybody have questions for Anjanette? You can put them in the chat or unmute, or if you're in person, you can shout it out. Okay. Well, next we're gonna have, I mean, that was great information, Anjanette. And next, hearing all that great information is always different than what a workflow looks like in person, especially from the clinic's perspective. So we have Laura Green from Aspire, and then also April Marsh from Northern Pines joining us to give a bird's eye view of what that workflow would look like in a practice. So really making a robust opportunity to provide CGMs to your patients. And what does that workflow look like in real life? So they will walk through their presentation. They each have some great information to share. And I know there's some tools built in there as well. So we will have them up next.
Hi, everyone. I am Laura Green. I am the Director of Population Health. And this is Ms. April. Let her introduce herself. I am April Marsh from Northern Pines Health Center, nurse care manager up there. So I am filling in for one of my care managers that they did not want to come and present. So I am doing just an overview of what they do in a clinic. Ms. April here is the real deal.
So I will ask both of you just to speak nice and loud to Mr. Howell here so our online folks can hear you, because you're both very softly spoken.
I have a really bad habit of speaking very softly. So if you guys cannot hear us, please yell at us. So Anjanette did a really great job of going over what the benefits of a CGM are. So our focus here is to bring it to you, bring you the information to you at a clinic level and how to implement that. So as you can see here, there's a plethora of benefits of why it would be good to have a patient on a CGM. Mindful eating, establishing long-lasting lifestyle modifications, lower A1C results. Now let me go talk to this.
So the first step is identifying patients that are good candidates for CGM. Of course, all type 1 diabetics and type 2 diabetics on insulin. We also like to look at any of our uncontrolled type 2 diabetics or even our pre-diabetics that might be good to help set them up with a 10-day sample in the office or identify them to the Stalo, which is an over-the-counter CGM that's available for patients. Assessing readiness, of course, there's going to be some patients that are like, oh no, I can't, technology. I've got 80 and 90-year-olds on a CGM that are, it might have taken them a little longer to get them set up and going. They've had to come in every 10 days so I could change it for them. But they're able to change it and manage it on their own now, so.
Okay, so I will speak to a little bit about the Dexcom and the Libre. So one of the important things when you're setting up your patients with either one of those CGMs is to ensure that you have them linked to your clinic. For patients who are on a Libre CGM, the CGMs can be uploaded remotely through the Libre View, and then the Dexcom Clarity, which I know April can even speak more to. Make sure that when the patient comes in, you link their Dexcom 7 to the Dexcom Clarity. That way when you go into the portal, you can upload those CGM reports remotely. You want to talk to the Blue Cross?
Yeah, Blue Cross Blue Shield does have a patient empowerment toolkit available for the, it's Blue Cross Blue Shield Commercial PPO that also have that PDCM provider delivered care management benefit, where they get a free 3-month freestyle Libre 14, a free blood pressure cuff, and a free weight scale through this program. So any Blue Cross Blue Shield is amazing. It's through JMB. It's really easy to send that order letter and get them set up with that.
Do you know if that includes Blue Care Network?
It does not. I just tried it on a Blue Care Network patient and it did not include it, unfortunately.
It's just commercial.
Mm-hmm.
Bummer.
Okay, so I will go through the Aspire workflow and how our one office who has an embedded care manager has been successful with implementing the CGM. So what she will do is she'll print off the monthly CGM report for each patient. She scans this report into the patient's chart, and then it's linked. The patient CGM is linked to the clinic using the Dexcom Clarity. Again, another important reason to have that link, so it's just easy to go in and print off. If the patient is not linked, she ensures that the next time that they come in, that she is able to connect them and upload the results into the patient's chart. So she ensures that when they come in, she's either linking them to the Dexcom Clarity or she's taking the cable and downloading those results. So then she does a process where she scans those CGM reports into the patient's records. She creates an encounter. She attaches the CGM to that encounter. And then what she will do is schedule a half hour with the provider and go over the CGM reports. And it's very quick. You have them all lined up and ensure that you've got the encounter in the EMR and reviews those with the provider. That way the provider can make the changes with her. If there's any medication changes, anything like that, it's all documented in the EMR. We are able to bill for that, and the code that we use is the 95251. That's reimbursable in a RHC. And then once that's all done, she routes that note to the provider and he signs off on it. If the provider wants any changes, she goes in ahead and contacts the patient and advises on any of those changes. I want to make a point too that if you're again linked to that Dexcom Clarity, you automatically get those 30, 60, 90-day CGM reports.
So ours is a little different, especially with the billing aspect. We use our care management and use the CCM codes and the PDCM codes. So we've got the Dexcom G7 10-day samples that we can use for any patient that we think needs to trial a CGM, whether it's getting them started on it. It's just doing that 10-day trial, just try and see that how they can change their diet to bring their blood sugars down to hopefully maybe lower their A1C, maybe not progress to diabetes. So that initial setup visit, I bill the CCM codes or a G9002 for that. And then I do get them set up with the Clarity app. I will, before they have an appointment with the provider, I will download that information from the Clarity app and then meet with the provider and review it so the provider kind of has an idea of what is going on with the patient's blood sugars before they come in for that appointment. If I do the sample, following up with them 10 days after to kind of see what surprised them, what changes they can make. A lot of times they'll do that 10-day sample and then decide that they do want to pay for that stay-low out of pocket because they just found it so beneficial to see what their blood sugars do 24/7. ordering for the insurance coverage, the insurances that do cover CGMs, utilizing Parachute. To order that through DME companies is so it streamlines the process, it reduces the amount of PAs that we get. And then also knowing if you need to send it to a DME company or a pharmacy, which I utilize the NCT2D coverage guide all the time for that.
Are you seeing a lot of co-pays? Or,
Not that I'm hearing. If there are, it's nothing too high where the patients are complaining to me.
So April and I kind of talked how important it is to have that Dexcom clarity because it kind of builds that report with the patient. They know that anytime you can get that report and check up and see how they're doing, it builds that trust with the patients and the relationships with them and also adherence that they're also monitoring what they're doing at home as well.
It does allow me for like the patients that I do follow on a monthly basis. They are expecting that phone call and it can be like, hey, what's going on with your blood sugars this last week when they're super elevated? And it kind of helps get them back on track instead of waiting the 3 months for them to come in and find out that they've been elevated the whole time.
Kind of just giving a little checkup on them. All right, so the initial CGM code, the 95249, the personal CGM startup and training is not individually billed. Cannot be reimbursed by the RHC, but we do get reimbursed by the CGM monitoring code, the 95251 that I talked about is in our process when we're going through with the physician and looking at all the monthly reports and then doing that streamlined process where he reviews them, the RN care manager, then routes that information to him and he signs off on it. So we do get reimbursed as an RHC and through the insurance companies for doing that.
And then I kind of went into a little bit. We do Medicare Advantage. We bill the CCM code 99490 for the initial setup, training, education. And then that kind of all goes into that time that my follow up and anything I do. And then Blue Cross Blue Shield, Medicaid, Priority Health. I do the G9002 for an in-office visit. If I talk to the provider, G9007 for that care conference with the provider. And then when I call them in 10 days, 98966, or if they come in to the office and meet with me to discuss their numbers, another G9002. And then the G9007 care conference with the provider when I am reviewing that information before they come in for an appointment.
So my question to you, April, is how do you keep track of all those different codes? I mean, with meeting with all these different patients and knowing what you've done with each one, I mean, do you have like a tracking sheet? What do you use to keep yourself capturing all the work that you do so you can get paid for it?
I do the service and then I open my note and chart right away. Or I chart by the end of the day and just.
So you don't
Sometimes
lose.
it's just like chicken scratch, what I'm writing down, what I'm doing, so I can remember, and then when I have time to sit down and chart, going back and getting it all in. I have, like my templates, G9002, I have a template for that, G9007, I have a template for that, so sometimes it's just opening those blank templates and then going back and
Filling it in.
filling it all in.
Because that's a lot of different codes to capture.
It is, see, I know all the codes, so it's like I'm throwing out these codes in there. I mean, it's really not a lot of codes.
You have it like math, so you know how when, like a mapping system that tells you when to use what?
I have a cheat sheet that I do
Okay.
give to like the care coordinators that say like, if you have this insurance, bill this.
Yeah.
And then if it's an in-office visit, you'll bill this code. If it's a phone visit and it's like 5 to 10 minutes, you bill this code. 11 to 19 is this code.
And I think that's the difference between being independent and necessarily working for a large hospital system. We only have one embedded care manager. The rest of them are centrally located and may go out to our clinics, maybe, 3 to 4 times a month or something like that. It's all a little bit different because each clinic has its own way of doing things. So it's a struggle trying to figure out how to balance it all too. Yeah. And we're still working through how to capture all of our reimbursement that we possibly can at a large hospital system.
So not only is it important to make sure your patient can afford it and they can get it, but also the services that you're providing, that you also get paid for those, that work as well.
And
Yeah.
one thing too, that I know Keisha, your practice manager, said that anybody that comes in with the two chronic conditions, you automatically sign up to be on the chronic care management program. Correct? So you're already, to be able to build a chronic care management diagnosis, like you are, they're already enrolled in her services for that too. So be cognizant of that, that she's using those codes, they're already on your services for that.
Or they might, I mean, obviously, anyone with diabetes, we do try and get on the chronic care management program.
Right.
So they're usually, the majority of our diabetic population has either me working with them or they're assigned to another one of our care coordinators.
How many care coordinators do you have in the department?
Right now, we've got me as a care manager and we've got Dawn as our care coordinator that has been there for a long time. We just hired one that starts Monday and are still looking for another one that's got kind of a behavioral health background.
Yeah.
Yeah, 'cause don't you guys have 9 providers?
No, we have one DO and a PA and NP.
Oh, we only had 3? I was thinking there's some more. Do you know what the cost outright would be if somebody's insurance didn't pay for the Dexcom?
The Stalo is $99 a month, or if they sign up for a monthly, like monthly shipments, it's $89 a month.
Okay.
So I do kind of talk to them like, hey, you can pay monthly and go 2 weeks on, 2 weeks off, and then try it that way to help with costs.
And then each of the websites, Dexcom, Libre, they do have those, patient assistance programs. So if someone's insurance doesn't cover it or no insurance,
That's a
there's
good point on
definitely.
each of that.
Yeah, that is great.
Do you also keep track, I'm guessing, the different codes? Because certain CGM codes are billable like 30-minute increments, but it's only so many times a month. Is that
So I know I'm not billing any of the CGM codes.
none of the CGM codes, the standard codes?
And we
Okay.
only know that one code is billable one time per month in an RHC, so you have to remember to differentiate the two.
Okay.
We both kind of, we're gonna touch on this. As you can see, here are some of the touch bases about if your patient's ready. I know April talked about that a little bit too. I know one thing we wanted to point out, I know Anjanette talked about it too, was the MCT2D. One of the benefits of being a patient-centered medical home is that you can also be, once you get enough diabetic patients, you're asked to be part of the MCT2D collaborative. And her and I were having a discussion that it's the Blue Cross Blue Shield patients that are no longer required a prior authorization for a CGM if you're part of that collaborative with MCT2D, P2D, because it's just one of the benefits of being a part of that.
United
collaborative.
Healthcare too is part of that,
Yeah.
where you can get it covered without being on insulin.
So I know there's probably RHCs out there that do qualify. I know you have to have a physician in order to be a patient-centered medical home, but it's really doing things that you are already doing in your clinic, but there are a lot of positives to being a patient-centered medical home, especially being able to be a part of MC2D, and that collaborative allows you to get an uplift on your Blue Cross Blue Shield billables within your clinic. But this is a really great program because it's a physician-led collaborative, and their website has a ton of resources that will tell you how to bill, like if your patient will be approved for a CGM or not. And I know April uses that, and a lot of my care managers use that a lot too.
And you don't have to be part of the collaborative to use the resources.
Correct.
I was using
Yes, let's
them
clarify
way
that.
before we were part of that collaborative.
Correct, and it's a physician-led collaborative, so it's people who are really passionate about diabetes care and what works best for your patients. And we can go through and look at, and you guys can read the key takeaways. I know we've talked a lot about all the great benefits of CGMs, but it's really finding the best workflow in your clinic that'll work best for you. You can tell that April and the clinics over at Aspire do it completely different. Not saying that there's a wrong way or right way, but really to get your providers trained, I guess, to start utilizing those codes and come up with a process that works best for your clinic, because it is reimbursable. And even if it's a small amount, it's still something that you're doing the work for, you should be reimbursed for it.
And it's really cool. I actually, with one of my samples, I used it for 10 days. So that way I could really have that experience to pass along to my patients, that this is how it works. And then being part of that collaborative, they also allowed sent us samples for our providers to try as well. So they were able to all try those to really just gain that experience and have that personal story to tell the patients.
Do we have any questions that we'll try to answer?
So do either one of you have a patient that comes to mind that just greatly benefited from having a CGM that really turned it around.
I would say that any of the 7 to 10 patients that were on in the one clinic that have CGMs, every single one of them has benefited. I don't think there was anything negative to say about the CGM.
I can't think of like one specific, but just everyone I've seen has been able to bring their A1C down.
Just lifestyle modifications that made them a part of they have to do at home to be successful, to be a part of their care.
I've had a few come off insulin,
Wow.
which is fantastic.
Lower cost, right? Less out of pocket, more money to go do the fun things they want to do.
Are those more of your type 1 or type 2s or both?
Type 2s.
Oh.
Usually we don't see a whole lot of type 1s. Usually I really try and get those to endo so that way they can do the CGM and pump.
Okay,
Yeah.
Works
that makes
together.
sense.
right.
But it brings up awareness to what they're wearing. I mean, because they're constantly going to check and they're like, oh, I
Yeah,
can correct
exactly.
this. It's just that
Uh-huh.
awareness of having it all the
Right,
time.
they'll say, oh, I guess I can't have a snack.
Right.
Or I should eat
Yeah.
this for lunch instead.
It's right in front of them.
You know, if I want to be bad a little bit later, I need to be a little bit, I gotta make some modifications throughout the day.
Yeah.
Awesome.
And also helps with portion control. So, like we would never tell a person, you can't have cake at your birthday or whatever, but wow, if I ate this size piece, it was manageable for me.
Exactly.
Or if I went for a walk after my meal, this is what it looked like. So.
Yes, making just those lifestyle interventions.
Mhm.
Any questions from the folks that are still online with us? Well, thank you, both of you, for sharing what you do out of your clinics, making CGM feel a little bit more possible. And certainly we will again share the resources that they provided along with their presentation, as well as the presentation. So happy to open it up for the next few minutes if there's folks online.